Esteemed Commission, dear participants, listeners, on the behalf of Student Scientific Society of Medical University of Silesia in Katowice, I would like to thank you all for coming and taking part in International Medical Congress of Silesia, in short, SIMC 2021 conference. My name is Martina Giaubas, and it is my pleasure to coordinate this second non-invasive cardiology session. I coordinately greet the scientific commission, which is composed of Professor Bożena Szczygóła-Jurkiewicz, Professor Maciej Wybraniec, Professor Maciej Kazimierski, Professor Rafał Młynarski, Professor Jacek Kowalczyk, Dr Mateusz Knop, and Dr Kinga Gościńska-Bliss.
Ladies and gentlemen, my name is Karol Kirstek, and I would like to share some information about the course of today's event. The order of the presentation is consistent with the order in the abstracts book. In the right order, every participant will be allowed to share the presentation. To share your presentation, please click the button Share Content on the bar below. The time for presenting is 7 minutes maximum and 3 minutes maximum for the discussion. If the presenter exceeds the time, he or she needs to move on to the conclusions and finish the presentation as soon as he or she can. Due to technical problems, we ask you kindly to watch the time individually.
We have a few words to the Commission as well. I would like to remind you that if you are a supervisor of work which is being presented to you, you must not evaluate the work. In that case, please cross out the number on your card. Other members of the same clinic are allowed to evaluate the presentation. The evaluation will be verified. I would like to remind that if the work is presented in English, the discussion also must be held in English. If the Commission will ask the question in Polish, the author of the work are obliged to answer in English. If the discussion is run in Polish, the additional points for speaking in English will be granted. Additional points for using English can be given from every Commission member when the discussion ends. If it was not held in English, every member of the Commission must give 0 points in the category.
The jury should assess scientific value, the way of presenting, discussion, own contribution, and 0 to 1 point for presentation and discussion held in English. After the session ends, we humbly ask you to send field report cards back to the session coordinator. Please send them via email on the same address from which you received the report cards.
Okay, I would like to ask the present of the paper entitled Pulmonary Embolism According to Age, Clinical Characteristic Management and Prognosis by Agnieszka Roy, Małgorzata Rodek, Patrycja Sowura, Patrycja Rozwadowska, Julia Samborska, Jakub Rybak. If the presenting author is ready, please feel free to start your presentation.
Thank you. I hope my presentation is visible on the screen. Thank you. Good morning, ladies and gentlemen. I would like to present to you our study entitled Pulmonary Embolism According to Age, Clinical Characteristic, Management and Prognosis. Pulmonary embolism is a major clinical challenge because it is the third after stroke and myocardial infarction, the most common cause of mortality from cardiovascular cases in the world. It is the most dangerous for elderly patients. The incidence rate of PE increases with age, especially from the age of 40. The aim of our research was to compare 3 groups of patients in different ages, vital clinical presentation, management, and in-hospital prognosis. A retrospective study was conducted on 101 patients with acute PE, including 40 females and 61 males with diagnosed PE admitted to the first department of cardiology in Medical University of Silesia between 2015 and 2020. I would like to highlight that not all the elderly patients were taken to the study, but all the young were. The patients were divided into groups based on their age. The first group contained 27 patients under 45 years. The second group, the control group, 44 patients aged between 46 and 75 years. And the second group with 30 patients above the 75 years. We collected the data concerning chronic diseases, risk factors, symptoms, prognostic factors, echocardiogram, laboratory tests, treatment and complications. The statistical analysis was made in Statisticaten software. The comparison between quantitative parameters was made by the human Whitney test and the quality parameters by chi-square test. The relationship between two variables was evaluated with the Spearman correlation coefficients. P-value less than 0.05 was considered significant. Here is the clinical characteristic of our patients. Hypertension was the most common chronic disease in all of our patients. And now I would like to present our results. Regarding gender distribution, there was a higher percentage of females in the elderly, 63.3%, and then in the control group, 27.3%. There was no difference in the distribution between the young and the control group, 33.3% versus 27.3% of all the patients. According to our research, the most common risk factors are sedentary lifestyle, 42%, nicotinism and prolonged immobilization, 28%, deep vein thrombosis, 27%, and obesity, 26% of all the patients. Another important issue are signs and symptoms. As you can see on the slide, dyspnea was the most common sign of PE in our study. Please look at the chart. Here you can see that dyspnea occurred more often in the young group, 81.5%, in comparison to 59 in the control and 63.3 in the elderly group. We also investigated other signs and symptoms such as cough, chest pain, hemoptysis, and syncope, but no significant differences were demonstrated. On the slide, we can see that our study revealed that troponin T and D-dimer levels were increasing with age. Other tests did not show any correlation or difference between study groups. Here we can see this correlation on the graphs. Here is a table presenting the echo. Lower left ventricular ejection fraction and shorter ACT was observed in older patients. And also there was a tendency to more frequent occurrence of McConnell's symptom. And the right ventricular dimension was similar in all groups. There are numerous ways that the embolic material closes the pulmonary arteries. So we checked whether the position of the thrombus correlated with age. The subtle PE had been detected in 7.4% of young, 11.4% of the control, and 10% of the older group. The most common was the lobar PE. Prognostic factors show that SPECI score was the highest in the elderly group, with the mean 1.3. In the control and young group, the mean was 0.7 and 0.4 respectively. Regarding the treatment, as we can see on the chart, thrombolysis was administered to the similar amount of patients in all the groups. And the last issue I want to talk about is the in-hospital cardiac arrest and death. According to our study, elderly patients had a higher risk of in-hospital cardiac arrest, 20% of them, in comparison to 4.5% in the control group, and the risk of death, 10% in comparison to none in the control group. One patient from the young group had a in-hospital cardiac arrest and died. It is the 3.7% of the group. In conclusion, I would like to tell that the most common symptom was dyspnea, which was more common in the young group. This demonstrates that pulmonary embolism can be a challenge in the elderly group. The troponin T and D-dimer levels correlated positively with age, indicating that older people have higher troponin T and D-dimer levels than the young people. The prognosis in elderly patients is worse in the early stages of the PE. The elderly group had a poor in-hospital and predicted 30-day outcome compared to the other groups. These results show that the age of patient could be a risk factor of PE and leads to worse prognosis. Thank you for your attention, and now I would like to invite you for the discussion.
Thank you very much for your presentation. And as you said, we would like to welcome any questions or your thoughts on the presentation. Okay, if there is no questions right now, maybe can you tell us something about your contribution to the presentation?
We have come with the idea of making the study. We have planned how the study should be held, and we gathered all of the data from the patient's cards. Then we made the statistical analysis and we analyze our results and make an abstract and all of this presentation.
Okay, thank you.
Thank you.
Are there any more questions someone would like to ask or thoughts that they came with? Okay, if no, we will proceed to the next presentation.
Thank you very much. I would like to ask to present the paper entitled Recurrence of Left Ventricular Systolic Function and NYHA Functional Class in Patients with Newly Diagnosed Acute Onset Dilated Cardiomyopathy by Aneta Zimolong, Sugarma Basansuren, Magdalena Balwierz, Miłosz Czempa, and Andrzej Halfar.
Good morning, ladies and gentlemen. My name is Aneta Zimolong and I represent Medical University of Silesia in Katowice. Today I'm going to present you a study concerning about recurrence of left ventricular systolic function and New York Heart Functional Class in patients with newly diagnosed acute onset dilated cardiomyopathy. Let me tell you a little about dilated cardiomyopathy. It is the most common form of cardiomyopathy among primary myocardial diseases. It can appear as increase of left, right, or both ventriculars impairment. Often occurs with congestive heart failures. Etiology is hard to precise. Characteristics and parameters of patients with newly diagnosed dilated cardiomyopathy with heart failure are still not known thoroughly. By heart failure, from accurate last month statement, we understand a clinical syndrome with symptoms or signs caused by a structural and functional cardiac abnormality and corroborated by elevated natriuretic peptide levels or objective evidence of pulmonary or systemic congestion. Consilium proposed 4 groups of classification of heart failure according to left ventricular ejection fraction level, which are preserved, improved, mildly reduced, and reduced where ejection fraction is equal or lower than 40%. The aim of our study was to assess relation between changes in echocardiographic parameters and clinical outcome in patients with newly diagnosed dilated cardiomyopathy heart failure. We conducted retrospective analysis of patients hospitalized as emergency cases in First Department of Cardiology in Upper Silesian Medical Center in Katowice. We collected data from August 2012 to May 2020, and there were 2,436 patients with heart failure and 265 patients with dilated cardiomyopathy. Our study inclusion criteria were an acute onset of heart failure, ejection fraction lower than 35%, and possibility of collecting follow-up. Our study exclusion criteria were symptoms of myocarditis, coronary artery disease, and occurrence of congenital heart disease. A mean follow-up period occurred at 12 months. We divided our patients into two groups based off delta ejection fraction named recovery, where ejection fraction was higher than 5%, and non-recovery, where ejection fraction was equal or lower than 5%. Finally, from all study group, from all patients, our study group was 27 patients, where 20 of them were males, mean age was 53, average of New York class was 2, and mean ejection fraction totaled 25. This table shows parameters that we assess in both groups. We can see that New York class in group of recovery was 2, in group of non-recovery totaled 243. Baseline left ventricular ejection fraction, left ventricular and diastolic and systolic parameters were higher in group of non-recovery, and successfully more hypertension incidents occurred in group of non-recovery. Our results. This chart shows comparison of level of ejection fraction after follow-up in both groups. We can see that in group of recovery, delta ejection fraction at admission was 19,2 and it increased to 13,4,6, which is statistically significant. In group of non-recovery, delta ejection fraction increased slightly. Decreased, sorry. This chart shows comparison of parameters of end-diastolic and systolic dimensions after follow-up in both groups. We can see that in group of recovery, end-diastolic diameter grew up to 8,4 and end-systolic diameter grew up 14,8. In group of non-recovery, end-diastolic diameter worsened and end-systolic diameter slightly increased. This chart shows comparison of New York Heart Scale after follow-up in both groups. We can see that in group of recovery after follow-up period, New York Heart Scale decreased, which is statistically significant. To sum up, we conclude that in patients with newly diagnosed heart failure in dilated cardiomyopathy, improvement of left ventricular systolic function is accompanied by reduction of New York Heart Functional Class and heart failure symptoms, and value of ejection fraction at baseline may be an indicator of a possibility of systolic function improvement. Patients with lower ejection fraction at baseline are more likely to improve. Thank you for your attention, and please feel free to ask any questions.
Thank you very much. Let us proceed to the discussion now.
Good morning. My name is Maciej Wybraniec. I would like to congratulate you on your results. I'm biased and I have conflict of interest because you from my the tutor of the work was from my department. I'd like to ask you a question about the methodology, because there's one very intrinsic feature of your inclusion, or of your endpoint definition, because you said that the non-responders or non-recovery were the patients with the delta LVEF below 5%. Was it so that the non-recovery group were patients in whom the increase was less than 5%, or there was even a decrease of LVEF, or were these patients non-recovery? Because you during the presentation you said that the non-responders were patients in whom there was a decrease of LVEF by 5%. Please specify. This is very important.
Good morning. If I may join discussion, I'm one of the co-authors of the study. Recovery group consisted also of patients which demonstrated decrease of ejection fraction. So not only improvement, but also decrease.
Mm-hmm. Okay, so I thought so, but I just wanted you to clarify it because like this identifies the population is very important. So
yes.
Mm-hmm. So how do you think, why it's so that patients who had baseline LVF lower had a better prognosis? What's your explanation of this phenomenon?
It may be correlated with the fact that patients who had higher basal ejection fraction, that their symptoms were less, they had lower time of medication. We can also say that patients in a recovery group were more used to symptoms, and therefore they had
Excuse us, but we cannot hear you. There are some technical issues. Ms. Shugama, do you hear us?
better progress. I can hear you. Oh.
There are some issues, so let us proceed to the next presentation. Thank you very much.
Thank you for your answers.
Oh, yes. Okay, so...
Okay, as we had some problems with receiving the full answer of Mrs. We will proceed to the next topic, which is non-invasive risk factor in patients with acute ischemic stroke, presented or constructed by Anna Lis, Paulina Lis, Weronika Łowiecka, Ewa Porwoł, Marta Polek, and Alicja Kaleba. So please go on with your presentation.
Yes, good morning. Just a minute. Is the presentation visible?
Yes, it is. Yes, it is.
Okay. And slides are changing, right?
Yes, that's right. Everything's working.
Thank you very much. Good morning. My name is Anna Lis, and on behalf of our team, it would be an honor for me to present our work on the subject of non-invasive risk factors in patients with acute ischemic stroke. Here you can see the table of contents. First, there will be a short introduction, then I will outline the aim of our study, next materials and methods, afterwards the results, and at the end, the conclusion. Let me start with a short introduction. As we can see here on figure 1, cardiovascular abnormalities, including coronary heart disease, cardiac failure, and especially atrial fibrillation, increase the risk of brain stroke. Consequently, there is a need of evaluating the assessment of non-invasive risk factors of sudden cardiac death. Such attempts were made, for example, standard deviation of all normal to normal intervals as a measure of heart rate variability. However, it did not distinguish between vagal and sympathetic effects. In other studies, it was demonstrated that impaired heart rate deceleration capacity is a powerful predictor of mortality after myocardial infarction and is more accurate than left ventricle ejection fraction. On this transparency, we can see a brief characteristics of different types of acute ischemic stroke based on its location. TACI, which means total anterior circulation infarct, it involves areas vascularized by anterior and middle cerebral artery, and non-TACI, which is PACI, partial anterior circulation infarct, which occurs in the area vascularized by anterior or middle cerebral artery. LACI, lacunar circulation infarct, which is localized in the deep cerebral white matter, basal ganglia, or brainstem. And POCI, posterior circulation infarct, which involves the basivertebral vascular system. The aim of our study was to assess sudden cardiac death risk factors such as HRV, HRT, DC parameters in patients with acute ischemic stroke. And DC means deceleration capacity by parameters of HRV, which is heart rate variability, I mean RMSSD, which is root mean square of successive differences, PNN 50, which is proportion of NN 50 divided by total number of NNs, SDNN, which is standard deviation of normal to normal RR intervals. And by parameters of HRT, which is heart rate turbulence, I mean HRT onset and HRT slope. Let me now switch to materials and methods. We assessed records from 7 days Holter monitoring during at least 2 years follow-up in 95 patients, 46 female and 49 male, with an average age of 60 years with standard deviation of 14 years. We divided them into 2 subgroups based on the location of the brain stroke, TACI, 35 patients, and non-TACI, 60 patients. Then we defined the composite endpoint, which consisted of confirmed atrial fibrillation or next brain stroke or hospitalization or death. And we assigned patients to the group with or without it. Here is the population's characteristics. You can see that we had a comparable number of female and male patients in each group. Average age was also similar in both groups. Scores obtained from Chudz-Vask and Hasbled scales, and so the NIHSS scores were higher in the group with composite endpoint. However, these differences were statistically insignificant. Now I would like to describe the results. Here you can see how many patients with TACR or non-TACI stroke were classified to the group with or without composite endpoint. Now, as we can see here, patients with composite endpoint during the follow-up had significantly lower RMSSD and lower PNN 50, HRT slope, and DC than patients without composite endpoint. Only the HRT onset was higher in the group with composite endpoint in comparison to the one without it. SDNN values turned out to be statistically insignificant. And here is a graphic presentation of our results. As you can see, RMSSD, PNN 50 were lower in the group with composite endpoint. HRT onset was higher in this group. HRT slope was also lower in the group with composite endpoint. And DC was also lower in the group with composite endpoint. And SDNN values turned out to be statistically insignificant. I would like to end by emphasizing main conclusions. Patients with composite endpoint had lower values of all assessed death risk factors apart from HRT onset, which was higher in the group with composite endpoint. It may suggest a higher risk of sudden cardiac death in this group. And assessment and observation of these factors variations may be useful in monitoring patients after acute ischemic stroke. However, further investigation of these parameters is necessary. Well, I have covered the points that I needed to present today. Thank you for your attention. And now I will try to answer the questions.
Thank you very much. So let's proceed to the discussion. Are there any questions? Okay.
Good morning, everyone. I have one question. Please, what is the main reason of collecting such parameters in your group of patients?
All these parameters define the sympathetic-parasympathetic balance, and this balance keeps also the proper heart rate. If this balance is disturbed and some arrhythmia occurs, it's a higher risk of, for example, next brain stroke. So every parameter that we can observe to catch it is needed.
Okay, thank you.
Thank you.
I would like to ask a question. What was the time frame between the Holter, the incident of the stroke and the Holter? So what was the time between these?
All the time of the follow-up was 2 years. It was average time of 2.5 years.
Okay.
Okay, thank you. Are there any other questions about the presentation presented to us? If no, we will go on to another presentation. Thank you.
Yes, let's move on to the presentation entitled Between Specialty Controversies on the Treatment of Cardiovascular Diseases During Pregnancy, a questionnaire study by Dominika Dziadosz, Katarzyna Dudzic, Irmina Morawska, Dominika Topolska, and Katarzyna Urban. Feel free to start your presentation.
Can you see my presentation?
Yes, we can see your presentation.
Okay. Good morning, everyone. My name is Dominika Dziadosz. I'm a fifth-year medical student representing Medical University of Silesia. Today, I have a pleasure of presenting to you our questionnaire study on between specialty controversies on the treatment of cardiovascular diseases during pregnancy. Thanks to development in medical field, up to 90% of women born with congenital heart disease live to adulthood. Increasing amount of women suffering from diabetes, hypertension, as well as the tendency to delay pregnancy are the reason why the amount of women suffering from cardiovascular disease during pregnancy is constantly growing. It is estimated that up to 4% of women will suffer from cardiovascular disease in the time of their pregnancy. It amounts to 15% of maternal mortality. There are many reversible hemodynamic changes happening in women's body in order to prepare her for pregnancy, delivery, and postpartum. But these changes can have a significant impact on the cardiovascular disease itself. The aim of our study was to compare the opinions of anesthesiologists, gynecologists, and cardiologists on the methods of diagnosis and treatment of potentially life-threatening cardiological diseases during pregnancy. Our research started in December 2019 and lasted until March 2020. We created a 19-question questionnaire, which was approved by Bioethics Committee. To record answers, we used 5-item Likert scale. We distributed the questionnaire via internet and on paper to Polish medical centers with departments of cardiology, anesthesiology, and gynecology. There were 111 respondents in total, in that 57 specialists and 54 residents. We recorded that answers to 8 out of 19 questions were statistically significant. Today, I'll talk about 6 of them due to the time limitation. 49% of surveyed physicians, mainly cardiologists, agreed that every woman with idiopathic pulmonary hypertension in reproductive age should use an effective method of contraception, regardless of the severity of the disease. It is due to the fact that pulmonary hypertension has a high maternal mortality, from 16 to 30%. Therefore, the recommendation to avoid pregnancy remains. However, 46% of doctors, including 58% of anesthesiologists, disagreed. Another controversy on pulmonary hypertension regarded the use of Swan-Ganz catheter. 61% of doctors, mainly cardiologists and anesthesiologists, disagreed that every pregnant woman with symptomatic pulmonary hypertension should have a Swan-Ganz catheter inserted for labor, and rightfully so, because routine monitoring with Swan-Ganz catheter is not recommended in the peripartum period because of the risk of complications, and other non-invasive techniques that assess cardiac output should be considered. It is worth noting that over 55% of gynecologists agreed with the routine use of Swan-Ganz catheter in this situation. There are published studies stating that there is a positive correlation between the use of beta blockers during pregnancy and fetal intrauterine development delay. There are also studies stating that there is no evidence of such correlation. This discrepancy is not only shown in the guidelines, but also in our research. 53% of doctors agreed that the use of almost all beta blockers in pregnancy may be associated with a risk of intrauterine fetal development delay, but 42% of them didn't. It is recommended by European Society of Cardiology that thrombolysis should be a method of treatment of pulmonary embolism in pregnant patients only in case of severe hypotension or shock, because administration of thrombolytic agents may result in fetal bleeding and even death. And 57% of doctors, mainly cardiologists, agreed with the guideline. However, 39% of them, including 70% of gynecologists, disagreed. It is also recommended by European Society of Cardiology that women suffering from severe heart failure, meaning New York Heart Association class 3 and 4 with reduced ejection fraction, should be discouraged from breastfeeding because stopping lactation reduces the high metabolic demand and enables early optimal heart failure treatment. Interestingly, over 83% of surveyed doctors, and that 90% of gynecologists and over 93% of anesthesiologists disagreed with the guideline. Difference in opinions arose on the topic of treatment of antiphospholipid syndrome with vitamin K antagonists. 55% of doctors wouldn't restart treatment with vitamin K antagonists from the second trimester of pregnancy. However, 32% of them, and that 69% of cardiologists would. It could be related to the fact that the European Society of Cardiology doesn't strictly prohibit from using vitamin K antagonists in the second trimester of pregnancy, but it is noteworthy that European Alliance of Associations for Rheumatology in its guidelines states that switching treatment from vitamin K antagonists to therapeutic doses of heparin is recommended as soon as pregnancy is confirmed, ideally before the 6th week of gestation because of the teratogenic effect of warfarin. Our research shows that this topic is remaining highly controversial. It is illustrated not only by the contrary published guidelines, but also in the opposing opinions of surveyed physicians. To conclude, diagnostics and treatment of cardiovascular disease during pregnancy remain a challenge. Conflicting opinions of surveyed physicians and contradictory guidelines show that pregnant patients suffering from CVD require a personalized treatment plan. And last, but certainly not least, a multidisciplinary approach is essential to ensure the highest level of care for the mother and the child. And my take-home message is, teamwork makes the dream work. Thank you for your attention, and I invite you to the discussion.
Thank you for your presentation. And as you said, we invite you all to join the discussion. Are there any questions? Okay, we have one.
Good morning. Very interesting work, congratulations. But I wonder if you look, who were the doctors answering the questions? If they work in the reference levels hospital or maybe they were in the smaller centers?
Population
of the doctors
participating? Responders of our study were residents and specialists of cardiology, anesthesiology, and gynecology. There were mainly doctors working at the tertiary centers, but we also decided to include doctors working in smaller hospitals.
But were there any differences between their answers?
Sometimes, but I would say that the main difference between doctors working at a tertiary center and a smaller hospital was the return rate of our questionnaire. Most of the doctors working at a smaller hospital didn't want to participate in the study because they said that they don't have experience in treating such difficult patients.
So they were most of the doctors were from tertiary centers, yes. Right? Thank you very much.
Thank you.
Thank you for your question. Are there any others?
Good morning.
Okay, we have one.
Good morning.
What is your personal input in the study?
My personal input was So let's start with the fact that our tutor came up with the idea of creating a questionnaire study on cardiovascular diseases during pregnancy. But when we as students started doing our research, we were very inspired by the guideline on the multidisciplinary approach. So we decided to put this in the forefront of our study. And we decided that respondents of our study would be the doctors that would be creating this multidisciplinary team. Then we created, as students, our questionnaire, but it was obviously checked by our professors from the Clinic of Anesthesiology and Intensive Care, and also from the first chair in Clinic of Cardiology in Katowice, in order to ensure that our questions were up to the newest data regarding the issue. Then we distributed the questionnaire ourselves with the use of internet and also in person. Then we created a database and we, as a student group, performed a statistical analysis. Then we wrote an abstract, and then I created this presentation that you're seeing today.
Thank you very much and congratulations.
Thank you.
If there are any other questions, we will go on and we will start to talk about CHA2DS2-VASc score, new fortune teller for NSTEMI patients. Presentation or work done by Karolina Jakubowska, Dominika Kiełb, Dominika Dziadosz, Tomasz Klocek, Magdalena Drewnowska, and Michał Skulik. So if you're ready, please start with your presentation.
Yes, hello, I am ready.
Hello.
Hello. Okay,
we can't see your presentation right now.
Yes, can you see it right now?
It's loading right now. We see not a proper view, we see your PowerPoint view. Okay, right now we see it.
Okay, so I think we can start now.
Yeah, sure.
So welcome ladies and gentlemen. My name is Karolina Jakubowska. And today, on behalf of my colleagues, I would like to answer the question if in cardiology, full of hard data, is there a place for a little fortune teller to foresee the future of NSTEMI patients? CHA2DS2-VASc is a widely known and used scale to assess the risk of ischemic strokes for patients with non-valvular atrial fibrillation. The very same peculiar name of the scale is giving away all its components. So we have the congestive heart failure, hypertension, age, diabetes, stroke or TIA, vascular disease, and finally the sex being female. All of those factors, in particular diabetes and congestive heart failure, can be considered a cardiovascular burden. And that's why the scale can be applied in many conditions, but especially in NSTEMI, as those patients are already in high cardiovascular risk. It got us all thinking, can the CHA2DS2-VASc score have an additional purpose? Can it be effective in predicting the 5-year survival among patients with NSTEMI? And so we started our research. We decided to perform a retrospective observational study on usefulness of various scales on patients admitted to the first chair and department of cardiology in Katowice between the November of 2013 and December 2014. The study consisted of 150 patients, half of them being male. We adapted inclusion criteria like age between 65 to 80 years, as well as, of course, the NSTEMI diagnosis. What is important, we decided to exclude all the patients with history of cancer. Our analysis was focused mainly on clinical characteristic and the 5-year survival. So what were the results of our study? Well, first of all, we noticed that the survival in our group was slightly over 50%, as only 82 patients had survived 5-year period after the NSTEMI episode. We took under consideration if different conditions are related somehow to the 5-year survival. It turned out that there is indeed a difference in morbidity between the groups, with the peripheral atherosclerosis, diabetes, and 3rd stage of chronic kidney disease. Those conditions had a statistically significant effect on death in 5-year follow-up. The same was checked for the medication that the patient has been treated with. There was a significant difference between the groups. What is interesting, taking loop diuretics and vitamin K antagonists had a negative effect on 5-year survival, as opposed to antiplatelet drugs and statins, which are shown to lower the risk of death in 5-year follow-up. But what is the most crucial for us, the group in which death was recorded presented higher results on the CHA2DS2-VASc score, the median being 5 points, with almost 40% sensitivity. Moreover, the CHA2DS2-VASc score above 5 can predict the death within 5 years with almost 40% sensitivity and 85% specificity. According to our observation, there is a statistical difference in 5-year survival in group of patients who achieved exactly 6 points in CHA2DS2-VASc score. But what would happen if we would exclude the two main conditions that are the known risk factors for the premature death that we discussed at the beginning of the presentation? As we can see, even after excluding diabetes or congestive heart failure, there is still a difference in score between the groups, even though the statistical significance has been reduced. Moreover, after excluding them both at the same time, the significance is lower, but the difference remains. When it comes to other scales that we took under consideration, like GRACE or CRUSADE, none of them has been statistically significant with predicting the 5-year survival. So taking in all the results and analyzing the post-infarction complication, we would like to propose a slightly modified score, CHA2DS2-VASc plus A, with an additional factor being infarction-related arrhythmia, which was defined as newly diagnosed arrhythmia right after the cardiac incident. The score above 5 in our modified CHA2DS2-VASc scale might be a pretty accurate predictor of death within 5 years. Both sensitivity and area under the curve were greater than in CHA2DS2-VASc alone. So returning to our question, can CHA2DS2-VASc scale be a fortune teller for the NSTEMI patients? The answer given to us by the statistic is yes. So what are the conclusions from our study? Well, first of all, CHA2DS2-VASc can be useful in predicting death in NSTEMI patients. Moreover, modified CHA2DS2-VASc plus A scale could be used in clinical practice for NSTEMI patients in the future, but further study regarding the topic should be performed. Thank you for your attention, and do you have any questions?
Thank you very much. So we will proceed with the discussion. Are there any questions? Okay.
Good morning.
Okay, we see you.
Good morning.
Good morning. What's your personal input in your work?
Yes, so the idea to try if the CHA2DS2-VASc scale can have an additional purpose was originally our idea. We collected the data of the patients that were admitted to the clinic in the years 2013 and 14. We analyzed the data that we gathered. Later on, we checked if the patients that were in our database are still alive. And of course, we prepared the abstract and the presentation.
Thank you very much.
Yeah, you're welcome.
Okay. Thank you very much. Are there any other questions? I don't see any. So we will go on with the presentation.
Now I would like you to present the paper entitled Acute Myocardial Infarction in COVID-19 and Non-COVID-19 Patients by Maria Stec, Daniel Gątko, Marta Gorczyca, Adam Grzebinoga, Jakub Roman, and Agata Suleja. Please start whenever you're ready.
Thank you. Just let me share my screen. Can you see it now?
Yes, we can see your screen.
I believe it should be fine. Just in a second. Right? Great. Good morning, ladies and gentlemen. My name is Maria Stec, and I'm very happy to present you today a paper on acute myocardial infarction in COVID-19 and non-COVID-19 patients. COVID pandemic has radically changed both our everyday lives as well as prognosis and clinical course of various diseases. AMI is one of the major cardiovascular diseases in which treatment and patient survival rate great improvement have been observed for past 40 years. However, the current epidemiological problem has changed it. This is why we decided to focus on the impact of COVID on the clinical course of AMI. The aim of our study was to compare the clinical profile as well as mortality and 3-month survival rate of patients with myocardial infarction with and without COVID-19 infection. The study was retrospective and cross-sectional analysis of 150 patients hospitalized between October 2020 and January 2021 in the first department of cardiology, Medical University of Silesia in Katowice. Among studied population, 33% of patients were female and the mean age was 74 years. Our methods included analysis of clinical characteristics as well as laboratory tests, inflammatory markers, echocardiography data, in-hospital mortality, then 3-month survival rate, and statistical analysis. Analysis of demographic data revealed that age and hospitalization time were statistically important. Generally, COVID patients were older and hospitalized for a longer period of time. 40% of COVID patients and only 31% of non-COVID patients suffered from STEMI myocardial infarction, but it was statistically insignificant. According to echocardiography data, according to echocardiography data, the most abundant localization of AMI among non-COVID patients was anterior and inferior wall, whereas in COVID population, the most abundant localization was inferior wall. Biochemical markers revealed that both troponin, CRP-R, and CKMB levels were significantly higher in COVID patients. Thus, we can assume more severe myocardial damage. Moreover, we detected positive correlation between troponin level and CRP concentration among COVID patients. What's interesting is that in non-COVID population, there was no such statistical correlation. Left ventricular ejection fraction was generally higher in non-COVID patients than in COVID group. Moreover, quite strong negative correlation between troponin concentration and left ventricular ejection fraction in the both COVID-19 and non-COVID-19 population was detected. Moving on to concomitant diseases, we detected that atrial fibrillation in COVID-19 patients was way more abundant than in non-COVID population. What's interesting that other concomitant diseases in COVID and non-COVID population did not statistically differ, although we decided to investigate both hypertension, diabetes, obesity, arteriosclerosis, chronic kidney disease, history of myocardial infarction, and history of stroke in both populations. On the other hand, there was major difference in occurrence of radiologically confirmed pneumonia. 40% of COVID and only 5% of non-COVID patients presented this condition. Furthermore, mechanical ventilation of 5% and of almost 30% of COVID patients was detected. Analogically, only 2.5% of non-COVID and almost half of COVID population patients had saturation lower than 90%. Generally, there were more hemodynamic interventions among non-COVID patients. According to gathered data, COVID patients presented more concomitant diseases, hence hemodynamic interventions were avoided due to various complications. The number of narrowed arteries varied between COVID and non-COVID patients. In 17% of COVID patients, there was no narrowed arteries, what explains rather low number of PCI interventions in this group. Moreover, it should be noted that 75% of non-COVID patients and only 54% of COVID population suffered from multivessel coronary disease. When it comes to pharmacotherapy, there were some differences between two analyzed groups. In the non-COVID population, AMI standard treatment was applied in the majority of patients according to the ESC guidelines. Whereas in COVID population, AMI standard treatment varied, and also quite a few pharmaceuticals, including heparin and antibiotics, as well as antivirus pharmaceuticals were added. When it comes to mortality, both in hospital mortality as well as 3-month mortality were obviously higher in the COVID population. The major incidence of death in hospital death in COVID population regarded patients ventilated mechanically. We are aware of the limitations of our study. We investigated only 30 COVID patients. Moreover, sets of laboratory data varied in many of our patients. Furthermore, only short TTE protocol was performed in COVID group according to the guidelines. However, the cause of AMI in COVID patients is currently debated in the leading medical journals, and our observations seem to be a supplementary material for the discussion. Based on the results of our study, we can conclude that COVID-19 infection significantly modifies the clinical course of AMI. Most severe myocardial damage corresponds with higher troponin and CRP levels related to inflammatory activation, and less invasive reperfusion treatment was observed in COVID patients. Furthermore, prolonged and complicated hospitalization and higher 3-month mortality rate was observed among COVID patients. Bearing in mind multiple coexisting risk factors as well as diseases, the course of AMI in COVID patients varied from AMI course of non-COVID patients. However, the topic of COVID influence shall be further investigated due to dynamic epidemiological situation and short period of hospital observations. Thank you so much for your attention, and I would be very happy to answer any of your questions.
Thank you for your presentation. So we'll proceed with the discussion right now. Are there any questions?
I would like to ask a question about the proportion of patients with acute myocardial infarction who underwent primary percutaneous coronary intervention, because you showed the data that only 68% of patients in COVID-19 group received dual antiplatelet therapy. So why this group of patients less frequently underwent PCI, and what would be your explanation for the phenomenon that a considerable proportion of these patients didn't have significant stenosis in the coronary vessels?
Thank you very much for this question. Well, firstly, fewer patients with COVID infection underwent PCI because I think they had way more concomitant diseases. Hence, here doctors try to avoid lots of complications which could be caused by those concomitant diseases. Moreover, well, I'm not sure how to explain fewer incidents of stenosis in COVID patients, but it is quite surprising, I think, that more non-COVID patients had multi-vessel coronary disease than in COVID group.
I just would like to, because it's a very interesting data you showed, I congratulate you on your results. And what I would like to stress is that the higher proportion of patients with COVID-19 and acute myocardial infarction have simply a prothrombotic state or MI of type 2 MI, a secondary MI. So they have simply hypoxia leading to ischemia, and in some patients it leads to myocardial infarction with typical STEMI presentation. And we saw patients with a very high ST segment elevation and no lesions in coronary vessels. This is a very typical scenario for a large proportion of patients with COVID-19, but simply it changes the clinical image of this clinical entity in our times. So it's a very interesting data. Thank you.
Thank you very much.
Okay.
One short question.
Yes.
Did you observe any significant differences with respect to time? For example, door to balloon time, etc., for COVID-19 patients?
Actually, I need to say that not that much data regarding those time frame was available. So we detected no significant differences between this data, actually. But we tried to analyze it, though.
Okay, thank you.
Thank you.
Thank you for your answers. If there are no more questions to be asked, we will go on with a paper named "Does the location of ischemic stroke correlate with different types of cardiac arrhythmias?" by Mateusz Marszałek, Magdalena Zapała, and Bartosz Zwiernik. If you're ready, please show us your presentation. Okay, we see it, just the full screen mode. Okay, we have it.
Good morning. My name is Mateusz Marszałek. It's a particular pleasure for me to talk to you about my presentation. The co-authors are Magdalena Zapała and Bartosz Zwiernik, and the title of our presentation is Does the location of an ischemic stroke correlate with different types of cardiac arrhythmias? I'd like to start by drawing your attention to the definition of stroke. Stroke is a medical condition in which poor blood flow to the brain causes cell death. Nowadays, stroke is one of the major global health problems, being the second leading cause of death in the world. In 1991, Oxfordshire Community Stroke Project proposed 4 easily defined subgroups of cerebral infarction. Patients were classified into TACI, PACI, LACI, and POCI. Moreover, there is necessity to add to these subgroups 2 other, TIA and RIND. Can we now turn to heart-brain axis? Cardiac arrhythmias alteration in stroke can appear in the context of a pre-existent cardiac disease, but also in its absence, in which case they have a neurologic origin. The most frequent arrhythmia in stroke is atrial fibrillation. We analyzed retrospectively 317 patients with ischemic stroke who have a 24-hour Holter recording performed after stroke during the hospitalization. We collected clinical data and Holter results from 3 years. I'd like to look at this with a bit more detail. We classified patients into 3 groups: TACI, 15 patients, TIA or RIND, 46 patients, and non-TACI, 256 patients. To the non-TACI group, classified patients with PACI, POCI, and LACI type of stroke. This proportion in differences in frequency of type of stroke is compatible with other studies. Having looked at our subject, let's now turn to the results. At this slide, we can see CHA2DS2-VASc score mean chart grouped by stroke type. CHA2DS2-VASc score was discretely highest in TIA or RIND group, but there was no statistical significance. If we now look at the National Institutes of Health stroke scale, NIHSS had the most significant value for TACI group, and obviously TIA or RIND scored the lowest. All obtained results were statistically significant. The average heart rate was similar in all 3 types of stroke, and there was no statistical significance. Moving on now to the question of what about supraventricular arrhythmias. If we look at the incidences of ectopic atrial tachycardia and atrial fibrillation separately, we can see that both are more common in a TACI group. On the other hand, if we take into account the presence of any of these arrhythmias in post-stroke patients, we can see a greater association with TACI. And here is the statistical trend. Supraventricular arrhythmias occur in nearly 70% of patients with TACI stroke. Let me now turn to ventricular tachycardia. In this analysis, we can observe the opposite trend. VT incidences are more common in non-TACI group. In our study, this arrhythmia didn't occur in any patients with TACI stroke. The incidences of bradycardia less than 40 seconds were the most common in TIA or RIND group. On the other side, the pauses of more 2 seconds in a non-TACI group. In our patients group with TACI stroke, these disorders didn't happen. Just before concluding, I'd like us to look at the chart. If we look at the TACI group in the graph, we see that its location indicated the most frequent occurrence of ectopic atrial tachycardia and atrial fibrillation, while the low index high shows the rarest occurrence in VT. The situation is somewhat opposite in the case of non-TACI. As the index in supraventricular arrhythmias is in the middle, but it's high, indicates a much more frequent occurrence of VT than in TACI. Furthermore, NIHSS had the most significant value for TACI group. Finally, I have some take-home messages for you. Cardiac arrhythmias occur in patients with acute stroke and may be risk factors. And supraventricular arrhythmias appeared more frequently in patients with TACI, while non-TACI stroke patients were more likely to develop ventricular arrhythmias. And let me finish there. Thank you, and we are open to any questions.
Thank you for your presentation. As you said, we welcome any questions from our listeners.
Good morning.
Hello.
Good morning.
I have, first of all, wonderful and important presentation. 2 short questions. What is practical value of the research presented by you? I mean, this information was during presentation, but I only would like to ask about short bullet answer. And the second one is, what is your contribution to the paper? Thank you.
Maybe I start from a second question. Me and my colleagues, in cooperation with our tutor, conceived and designed this study. Together we collect and analyzed the data. I wrote the manuscript and make statistics, and the other co-authors designed the presentation.
So maybe I answer about first question. I am a co-author of the study. My name is Magdalena Zapała. It's difficult to answer because our research suggests a link between arrhythmias and strokes, but we know that this study has some limitation. So we think that there is need to broaden and investigate this problem more in the future, and maybe in this situation, the result will be more, the best and more than at this moment.
So to be concluded, more research is needed. Fantastic presentation. Thank you so much.
Thank you.
Are there any others? If not, we will proceed.
Good morning. I would like to ask a question, if it's possible. I would like to ask what exactly prompted you to take up this specific topic?
Could you? Okay.
Could you repeat? Because I have some problems with my speakers.
What exactly prompted you to take up this topic?
Good morning. My name is Bartosz Wiernik. I'm co-author of this study. Me and my colleagues, Magdalena and Mateusz, are interested in cardiac arrhythmias. So we chose this topic because, as Magdalena said, research revealed a few articles in the past 10 years specifically investigating ischemic stroke and cardiac arrhythmias other than atrial fibrillation. And that is the result why we choose this topic to present to our.
Okay. Did you receive the answers for the questions?
Yes, thank you very much.
Okay. If there are no more questions to be asked, we will proceed with hypertrophic cardiomyopathy and ECG criteria for detection of left ventricular hypertrophy by Mateusz Tomaszek, Joanna Bisaga, Michał Razik, Barbara Rozpiątkowska, Bartłomiej Feret, and Jan Ciapraga. I'm sorry for. Okay, we see your screen. Just a full screen mode, please. Okay, we see your presentation now.
We can't hear you.
But we cannot hear you, and I don't think we can see you.
Now I'm hearing.
Now
we can hear you. I'm not sure if we can see you. Can we see you?
Now I'm hearing.
Yes, we can see you. Visible and audible.
Now it's okay?
Yes, everything is okay. You can go on with your presentation.
Okay, thank you. Honorable committee, dear colleagues, my name is Mateusz Tomaszek, and I am a student of 4th year of medicine studies in Medical University of Silesia. I have pleasure to present you the results of our study, hypertrophic cardiomyopathy and ECG criteria for detection of left ventricular hypertrophy. Hypertrophic cardiomyopathy is a genetic disease inherited autosomal dominantly. It often occurs in population. Hypertrophic cardiomyopathy results in abnormal thickening of the myocardium. It can be asymptomatic, or the first symptom can be sudden cardiac death. Diagnostic is usually based on electrocardiographic and echocardiographic examinations. The slides present our patient's ECG and TTE. The aim of our study was to evaluate the features of left ventricular hypertrophy in ECG in patients with hypertrophic cardiomyopathy in relation to risk of sudden cardiac death. We created an extensive database, including patients hospitalized from year 2015 to 2021 in tertiary cardiologic center. We analyzed manually ECG records and calculated 5-year score of sudden cardiac death using European Society of Cardiology calculator. We analyzed data using Chi-square test. We included patients with left ventricular wall thickness above 15 millimeters, and we excluded patients with severe hypertension, severe valve disease, and major conduction disorders. We analyzed 12-lead 30-second ECG records. The 8 criteria of LVH were assessed: the Sokolov-Lyon, Cornell, Gabner-Angel-Leider, and 5 other criteria presented on the slide. The database consists of 71 patients. The mean age was about 52, and the mean BMI was within normal range. Only 41% of patients never smoked, and the most common comorbidities were dyslipidemia, mild hypertension, and ventricular tachycardia or fibrillation. 80% of patients had family member diagnosed with hypertrophic cardiomyopathy. 23% of patients had sudden unexpected death in family history, and 47% of patients had family history with cardiovascular diseases. 40% of patients had ICD, and the most common presenting symptom was dyspnea on exertion. Results of our study. The most of patients had sign of left ventricular overload in ECG. 37% of patients met Cornell criterion, 32% R-wave in V6 greater than in V5, and 31% R in AVL greater than 1.1 millivolts. All criteria were statistically significant. Patients were divided into 3 groups due to LVH ECG criteria. No criteria were presented by 41% of patients, 1 criterion by 20%, and 2 and more criteria by 49% of patients. We have divided patients into 3 groups due to a 5-year risk of sudden cardiac death. The low risk group consists of 63% of patients, intermediate group of 9%, and high risk group of 28% of patients. In the low risk group, 62% of patients met criteria, including 29% 1 criterion and 71% 2 and more criteria. In the intermediate group, all patients meet criteria, including 20% 1 and 80% 2 and more. In high risk group, 60% met criteria, including 33% 1 and 67% 2 and more criteria. Further investigation has shown that a high risk group was overestimated. There were patients with amyloidosis, and they accounted for 25% of this group. Conclusions. Less than 70% of patients met LVH criteria in ECG. Patients with high risk of sudden cardiac death more frequently presented positive LVH criteria in ECG, but not all of these patients. And to sum up, our study proves that ECG analysis require further diagnosis of LVH origin. And I want to point out that our study is still being continued and a database is being extended. Thank you for your attention and invite for a discussion.
Thank you for your presentation. And as you said, we would like to invite you to asking questions. Okay, we have the first person to ask the questions.
Because the ECG voltage criteria for hypertrophy are important clinically, but how do you think, what is the significance of right now in the era of echocardiography and very diligent imaging techniques? Do we still need this voltage criteria? Because actually, this is very important for you as students and for your future work. How do you think, you have a patient with arterial hypertension, he comes to you, and what does it tell you? How can you use clinically this voltage criteria? Why should we assess it?
Thank you for this question. In my mind, this criteria is still important, for example, for general practitioner, because it's very quickly and cheap and available reason for first diagnostic, and it can help with make another it can help with further diagnostic into cardiology or another specialist. So I think it's important for first diagnostic. For cardiology, obviously it's more important TTE or genetic investigation for hypertrophy, but it's even important for me for first diagnostic.
Mm-hmm. Thank you for your answer. I just wanted to stress the fact that voltage criteria are important for patients with arterial hypertension because you don't do transthoracic echocardiography in all patients with arterial hypertension. You should refer patients who actually have this voltage criteria or symptoms of heart failure. So actually these voltage criteria tell you whom to refer for echocardiography. And also sometimes these voltage criteria help you to assess the ST segment depressions, because in patients in whom these criteria are present, you may say that these are signs of left ventricular overload. So thank you for your answer. Let's think broader, not only hypertrophic cardiomyopathy, but let's also associate it with other diseases more frequent, such as arterial hypertension. Thank you.
Thank you for this comment.
Okay, thank you for both the question and the answer. So if there are no more questions, which I don't actually see, we will follow on with another paper.
Let's move on to the work entitled Correlation of Patients' Functions with Risk Factors for Cardiovascular Disease in Systemic Lupus Erythematosus Patients by Piotr Gręblowski, Dominika Blachut, and Jan Harpula. Please start whenever you're ready. We can see your desktop, but not the presentation.
Okay, can you see the presentation now?
Yes, we can see, but we cannot see you.
You are visible, so it's okay. You can talk now.
Okay. Good morning, ladies and gentlemen, dear jury. My name is Piotr Gręblowski, and I represent the Medical University of Silesia. Today, I am honored to present our work about correlation of certain parameters in systemic lupus erythematosus patients with cardiovascular risk factors. Systemic lupus erythematosus is a rare autoimmune disease. In this disease, the immune system attacks healthy tissue mistakenly. It can affect skin, joints, kidneys, brain, or heart. Pathogenesis involves antibody production and generalized inflammation of many different organs. Cardiovascular manifestations include inflammation of pericardium, myocardium, endocardium, and endothelial inflammation that may lead to atherosclerosis. The main aim of our study was to assess cardiological parameters in SLE patients and whether there was any link between our test results and the disease. The study group was enrolled in the time from October of 2018 to February of 2021. We have excluded any patients with other connective tissue diseases and chronic inflammation from the study. SLE disease activity index was used to assess activity of the disease with a cutoff point of 6 for active disease. Each patient underwent the measurement of carotid femoral pulse wave velocity, 6-minute walk test, and ankle brachial index. After the tests, we compared the data between the study group and the control group. The control group had been chosen in respect of age, sex, and cardiovascular risk. The experimental group consisted of 65 patients suffering from SLE. Control group consisted of 45 patients. Mean duration of SLE was roughly 8 years. On average, SLE disease activity index value was 6.35 points. And 15 patients had above 6 points, which meant active disease for us. Substantially more often, arterial hypertension and ischemic heart disease occurred in the SLE group. Left ventricle ejection fraction was statistically lower in SLE group, and also negative correlation was found between disease activity and left ventricle ejection fraction. Ankle brachial index was higher in SLE group. In case of 6-minute walk test, patients with SLE were able to walk a shorter distance. A statistically significant correlation was ascertained with risk factors of cardiovascular disease, such as number of package years and the fact of having been smoking in the past for augmentation index. Also, a glucocorticosteroid therapy was correlated with augmentation index. Positive correlation between 6-minute walk test score and ankle brachial index was determined, and no correlation was found with carotid femoral pulse wave velocity. No correlation between carotid femoral pulse wave velocity and ankle brachial index was found either. So to conclude, we think that the activity of the disease is a significant parameter that impacts the differences in the assessment of cardiovascular system in comparison to the control group. Also, glucocorticosteroid treatment and smoking in the past or the present will link that to higher risk of cardiovascular disease in these patients, and we also think that activity of SLE could be a potential factor that causes left ventricle damage. Thank you very much for your attention.
Thank you very much for your presentation. Are there any questions to be asked? I can't see right now. Okay, we have a question.
Thank you very much for your presentation. I have one short question. Did you analyze the role of renal function in your study? Because as we know, the renal dysfunction has a crucial role on the outcome in patients with cardiovascular diseases, but also in SLE.
We didn't do that, but we plan to extend this research in the future, and we will surely include that then.
Okay, I understand. It is worth incorporate in your study protocol renal function parameters.
Thank you.
I'd like to ask you a question about the, how do you think, is only systemic lupus erythematosus the only autoimmune disorder that increases the cardiovascular risk of patients? How do you think? What's your opinion about that?
I think that any systemic disease that's of autoimmunologic origin would affect the cardiovascular system. Yes, I think that there are many other diseases that should be considered if it comes to assessment of cardiovascular risk, cardiovascular disease risk.
Yes, we should associate all the patients with autoimmune disorders as those who require some a more precise cardiovascular assessment as they have higher cardiovascular risk. And they also have sometimes higher risk of some specific cardiovascular disorders, such, for instance, systemic sclerosis can lead to pulmonary arterial hypertension, and as well increased classic cardiovascular risk leading to atherosclerosis. Thank you.
Thank you.
Okay, thank you for your questions. Thank you for the answers. And if there are no more questions, we will carry on.
Let's move.
Okay. Is the newest question?
Are there any more questions? If not, let's move to the next presentation entitled Sacubitril and Valsartan across the spectrum of patients with heart failure with reduced ejection fraction by Rafał Niemiec, Irmina Morawska, Maria Stec, and Victoria Kuczmik. Please feel free to start your presentation.
Okay. Is the presentation visible?
Yes, it is.
Okay. Good morning, ladies and gentlemen, distinguished members of the jury and my fellow co-authors. My name is Irmina Morawska, and I would like to present the work entitled Sacubitril/Valsartan across the spectrum of patients with heart failure with reduced ejection fraction. Heart failure is a significant problem among older and young society. As we can see, 50% of patients die within 5 years of being diagnosed. Due to frequent hospitalizations and high mortality, new therapeutic methods are being sought. One of them is sacubitril/valsartan. The combination of a novel neprilysin inhibitor and an angiotensin II receptor blocker represents a new class of medicines known as angiotensin receptor neprilysin inhibitors. The aim of sacubitril/valsartan is to treat HFrEF in patients classified under New York Heart Association, 2nd class up to 4th class. Sacubitril/valsartan has been available in Poland, as we can see, since the turn of 2017 and 2018, and we try to use it based on the latest medical reports. Over the last years, new expert recommendations have been published, suggesting the use of sacubitril/valsartan in a larger group of patients, where finally sacubitril/valsartan is recommended ahead of all other renin-angiotensin and aldosterone system inhibitors in HFrEF therapeutic algorithm. The aim of our study was to compare clinical profile and mortality in patients with heart failure with reduced ejection fraction receiving and non-receiving sacubitril/valsartan. The study was conducted as a retrospective cross-sectional analysis of 1,062 consecutive hospitalizations for heart failure in the first department of cardiology, Medical University of Silesia in Katowice between 2018 and 2020. In our analysis, we included only the first hospitalization of individual patients. In this way, we obtained a group of 850 patients with heart failure. Among them, we distinguished 613 patients with HFrEF. Then we divided this group into two subgroups. 82 patients receiving sacubitril/valsartan and 531 patients non-receiving sacubitril/valsartan treated with RAAS inhibitors. The next step in our work was to select the control group of a subgroup from a subgroup of 531 patients who were untreated with sacubitril/valsartan. And due to the lack of data, we finally included 64 patients from SV subgroup and 432 patients from non-SV group in our analysis. Then, based on SV subgroup, we included age, sex, BMI, and LVF, Matching was performed by using the one-to-one nearest neighbor method without returning, as we can see in the slide. Finally, 2 subgroups of 64 patients were obtained. Then, when we look at the value in the lower table, we can see that we managed to get 2 very similar populations in terms of the compared factors. Clinical characteristic and mortality in 1 up to 2 year follow-up were our outcomes. The results of our work are as follows. The frequency of sacubitril valsartan use increases from year to year, from almost 8% in 2018 to almost 23% in 2020 among patients hospitalized due to HFrEF. We included multiple markers used in the clinical characteristics of our subgroup that independently influenced the follow-up. Initially, we compared 2 subgroups in terms of the occurrence of the factors listed in the table. Then we tried to find the independent risk factors for death. Comparing the 2 subgroups, we observed that the subgroup receiving sacubitril valsartan had a post-infarction cardiomyopathy, atrial fibrillation, and cardiac resynchronization therapy significantly more often. We proved that in the non-SV subgroup, advanced tricuspid regurgitation increased the death incidence. Surprisingly, coexisting hypertension and coronary arterial disease decreased the death incidence. On the other hand, in the SV subgroup, coexisting atrial fibrillation decreased the death incidence. In both subgroups, mortality was associated with higher New York Heart Association class. We have assessed the occurrence of mortality, and there was no difference between the subgroups, as we can see. 18 out of 64 patients died in every subgroup, which constitutes 28.1% of a particular subgroup. Finally, we are coming to the conclusions. On the grounds of our study, we have observed that our current experience in sacubitril valsartan therapy is limited to the extremely severe patients with HFrEF, which undoubtedly affects the obtained results. Mortality in HFrEF population is high, and despite the coexistence of multiple risk factors for death, advanced heart failure seems to be the most important factor influencing the high death ratio. Despite evidence demonstrating the benefits of sacubitril valsartan therapy over standard of care, only a fraction of eligible patients takes the drug. Barriers preventing the prescription of sacubitril valsartan may include practitioners' unfamiliarity with angiotensin receptor neprilysin inhibitors, safety concerns, and payer reimbursement issues. Thank you for your attention, and I would like to invite you to the discussion.
Thank you for your presentation. Are there any questions?
Please tell us what is your contribution to this study. In fact, this question should be mandatory for all presenters.
Okay, thank you for your question. Our contribution to the work was to collect the data. As I mentioned, we collected more than 1,000 patients into this research. Then we did the biostatistical analysis by ourselves, but with matching, we asked for the help more experienced person. And then we prepared this presentation for the conference, and now we are working on the article.
Okay, thank you.
Thank you, thank you.
For your question and answer. Are there any other questions?
I'd like to ask you, because you said that the matching was performed by some other person, but it's a very crucial element of this study, because I guess you used propensity score matching technique. And this technique involves certain variables that are included in the model that match both populations. So maybe I missed it, but did you have the list of variables that were used for matching both groups? Because
yes, I have mentioned that in the presentation. We used the left ventricular ejection fraction. Then we used the BMI, sex, if the person was female or male, and we included also age of patient.
Okay, thank you for your answer. It's very important because the matching is simply the information that they were matched is not enough. Thank you. But my last question is about clinical of your clinical knowledge. How do you think? Can you just simply introduce sacubitril/valsartan to a patient with heart failure? Treated with ACE inhibitors or angiotensin receptor antagonists, or you simply need to do something? How do you think? Can you do it instantly?
Unfortunately, sacubitril/valsartan is still the very new drug, so that we don't have the solid regulations and recommendations of implementing that drug. And when we decide to use sacubitril/valsartan, we personally, I think that we have to be a very experienced doctor to implement that drug. Personally, I trust this drug, even still we are waiting for the recommendations. I know that probably in September this year there will be the update of implementing that drug. So that's, I think that the use of sacubitril/valsartan will be more popular when we have the solid basis of the usage.
I may join the conversation. I'm one of the co-authors. When we want to introduce sacubitril/valsartan, it's important to check the kidney function and the potassium level. And there are strict criteria when we can use the sacubitril/valsartan. It's in the recommendations, so we should check a few things before we include sacubitril/valsartan in the therapy.
Thank you for your answer. I just, yes, the kidney function, the eGFR and the hyperkalemia are something you should watch for. But the other thing is that you need to wait 36 hours after last dose of ACE inhibitor, of angiotensin receptor blocker, before you administer the first dose of RNA. So that's why I just wanted you to remember it, and it's quite important. Thank you.
Congratulations, very good presentation. I have one short question. Do you know if we can use these drugs in the pediatric population now or maybe in the future?
Personally, I didn't find any papers that are suggesting the usage of this drug for the pediatric population, but I hope that the scientific researchers will provide this drug for small patients.
Thank you.
Okay, thank you for your question. Thank you for your answers.
Thank you.
We will carry on with the presentation by Tomasz Klocek on the paper named Prevalence of Obstructive Sleep Apnea in Patients with Pulmonary Arterial Hypertension, the work by Tomasz Klocek, Magdalena Drewnowska, Karolina Jakubowska, and Mateusz Gochowski. Okay, we see your presentation. We see you.
Okay, can you hear me?
Yeah, we can hear you. Right. Please go on with your presentation.
Good morning, ladies and gentlemen. My name is Tomasz Klocek, and I know that at this point of this session, everyone is probably very tired, and half of the participants would like to go to sleep. But the topic of sleep is what I've actually wanted to talk about a little bit more, especially the topic of lack of sleep among the patients with pulmonary arterial hypertension, who more often suffer from conditions that reduce the quality and quantity of their night sleep, The main of those conditions being obstructive sleep apnea. Those conditions result in lack of concentration throughout the day and many more complications. So in our study, we decided to evaluate the prevalence and severity of obstructive sleep apnea among patients with pulmonary arterial hypertension who were treated in the first chair and clinic of cardiology in Katowice between January 2019 and March 2021. Out of 54 patients available for this treatment, 38, unfortunately, were excluded, mainly due to the lack of consent and severe respiratory illness, which required oxygen therapy. The subgroup of 16 patients, 5 of them were male. The mean age of 58 years and the WHO scale of pulmonary arterial hypertension severity, which varied from 1 to 4, were admitted to the study. For it, we used the polygraph as seen on this slide. It consisted of the main device, which recorded the data, the nasal cannula for ventilation monitoring, and also 3 ECG electrodes and 2 belts, which registered both chest and abdomen movements during the sleep. It also consisted of the secondary device, which was connected to the pulse oximeter. We attached those appliances to the patient right before their night sleep and deattached them the next morning. As you can see on this picture right here, the whole attachment process wasn't always easy. The results of our study are, as you can see on the slide. Noteworthy is the apnea-hypopnea index, the main measurement needed to diagnose obstructive sleep apnea. And as it can be seen here, the mean AHI of this group was equivalent to moderate severity of OSA. Also, median values of our study group from the mean value of the night sleep of blood oxygen saturation and the minimal value of blood oxygen saturation recorded were well below physiological norms. Out of 16 patients qualified for our study, based on the AHI criteria, 15 of them were diagnosed with obstructive sleep apnea. This comprised the 98% of our study group. 8 of those patients were diagnosed with mild obstructive sleep apnea, 6 with moderate severity, and 1 as severe. We decided to investigate the relation between the severity of obstructive sleep apnea, the severity of pulmonary arterial hypertension based on the WHO scale, and the applied treatment. Unfortunately, it turned out that no matter the WHO scale nor the number of medications taken by the patient, they were all in both mild and moderate OSA severity groups. Noteworthy is that the one patient with severe obstructive sleep apnea was categorized as stage 3 of WHO pulmonary arterial hypertension severity scale and was treated with 3 different drugs, which is the most complex treatment available. So to conclude this study, obstructive sleep apnea seems to be a relatively common condition among patients with pulmonary arterial hypertension, but further enlargement of the group is required to evaluate any connection between those conditions. And since early diagnosis of obstructive sleep apnea among patients with pulmonary arterial hypertension can be an argument for an earlier start of oxygen therapy, further research could significantly improve patients' lives. Thank you for your attention, and I encourage the discussion.
Thank you for your presentation. First of all, could you tell us something about your contribution to the presentation?
Well, as for our contribution, we qualified the patients for this study. We've analyzed the exclusion criteria, and then we attached the polygraph to those patients before the night sleep. We deattached this appliance the next morning. And later we analyzed the data that was gathered from the polygraphy. We analyzed their treatment and also the severity scale of pulmonary arterial hypertension. We've made a statistical analysis of this phenomenon and the relationship between those conditions, and prepared the presentation.
Okay, thank you for the answer. I don't see any other questions. And as I know, you have another presentation waiting for you, so I will not keep you with us. Thank you for your presentation once again.
Thank you very much.
Okay, and as that was our last presentation, I would like to say that all the submitted papers have been presented. And we shall congratulate to all of the presenting authors and participants of our non-invasive cardiology session. At this point, I would like to ask the jury for a few words to sum up our session. And if I could ask for kindness of Professor Bożena Szczygła-Jurkiewicz to join us and say something about our session. Sadly, I cannot see a professor, so if we could ask for a few words of a summary, Professor Maciej Kazimierski. So maybe...
Okay, so maybe I'll sum up, Maciej Wybraniec.
Thank you very much.
I'm really impressed by the really astonishing work you made, and these presentations are really brilliant. And especially, I would like to say that the data you gathered is in majority of cases was very high load, high volume. So you included a lot of patients. And I really understand how much work it's required. So I once again would like to congratulate you on your results. And I think that you should definitely plan to publish your results, because this presentation, this conference is very important, but the most important for you is to publish as much as you can, because it's enables you to share your findings. And every work, every paper you write, it makes you wiser and more, I'd say, in depth with medicine. And simply, it's a very, I mean, scientific work doesn't make you, doesn't improve your contact with the patient, doesn't help you earn more money, but it may definitely help you to be better doctors, because it is a time for you to think it through, to have some other ideas on management of patients. So definitely it's worth spending your time and effort to publish and to do scientific work. So once again, congratulations, and also congratulations for all the organizing committee. So keep up the good work.
Very much. Thank you very much for your observation and for the knowledge that you shared with us, Professor. I think that was pretty valuable for all of us, both presenters and listeners, to this session.
We would like to cordially invite you to the festive summation of the conference and announcement of the results today on 4:30 p.m. Honorary lecture on the history of obesity will be delivered by Professor Michał Cholecki, the curator of the STN. This event will be transmitted via YouTube platform, and on the behalf of Student Scientific Society, I would like to thank you for participation in this session, and see you around.
Cześć, Kasiu. Witam, panie profesor. Cześć, Aniu.
Dzień dobry, dzień dobry. Miło widzieć pana profesora. Tylko szkoda, że i pani profesor, dzień dobry, bo teraz właśnie widzę, że pani profesor też jest. Dzień dobry. Szkoda, że nie w bezpośrednim kontakcie.
Tak, już widzę, przygotowują.
Dzień dobry jeszcze raz.
Dzień dobry Państwu.
wannie, na kanapie, w bibliotece ze znajomymi.
W gabinecie przy herbatce, z muzyką w tle.
Przy biurku, we własnym domu, ewentualnie z kotem na kolanach.
Najbardziej to lubię wieczorem.
Ale w efekcie często siedzę cały dzień.
Lubię na papierze.
Tylko online.
Lubię regularnie.
Lubię efektywnie. Lubię elastycznie.
No i wtedy praca to przyjemność.
I właśnie dlatego lubię więcej niż lek. Lubię więcej niż lek.
Lubię więcej niż lek.
Kurwa, rozładował.
Przepraszam za problemy techniczne, jak zawsze coś musiało się znaleźć. Esteemed guests and participants, ladies and gentlemen, on the behalf of organizing committee, we would like to cordially welcome you to the festive summation of the International Medical Congress of Silesia 2021. Szanowni Państwo, szanowna Pani Rektor, szanowni profesorowie, drodzy goście, a przede wszystkim szanowni uczestnicy naszej konferencji. Nazywam się Marianna Łoskot, obok mnie siedzi Piotr Lewandowski i w imieniu organizatorów konferencji, to jest Studenckiego Towarzystwa Naukowego Śląskiego Uniwersytetu Medycznego w Katowicach, Samorządu Doktorantów Śląskiego Uniwersytetu Medycznego w Katowicach, a także Polskiego Towarzystwa Studentów Stomatologii Oddział Zabrze. Chciałabym serdecznie przywitać Was na gali wieńczącej International Medical Congress of Silesia 2021. SIMC w skrócie. W szczególny sposób witam przedstawicieli władz naszej uczelni, prorektor do spraw nauki, profesor doktor habilitowaną nauk medycznych Katarzynę Miję-Stec, która reprezentuje jego magnificencję rektora Śląskiego Uniwersytetu Medycznego w Katowicach, pana profesora Tomasza Szczepańskiego. Witam także obecnych tu dziekanów wydziałów naszej uczelni. Dziekan Wydziału Nauk Medycznych w Zabrzu, panią profesor Alicję Grzankę, prodziekan do spraw studenckich Wydziału Nauk o Zdrowiu w Bytomiu, pana doktora habilitowanego nauk o zdrowiu Grzegorza Dziubanka, profesora SUM, prodziekan do spraw studenckich Wydziału Nauk o Zdrowiu w Katowicach, panią doktor habilitowaną nauk o zdrowiu Annę Brzęk, a przede wszystkim serdecznie witam kuratora STN w Katowicach, pana profesora Michała Choleckiego, który wygłosi za niedługo dla nas wykład honorowy pod tytułem Historia otyłości.
pełny ekran.
No dalej. Okej. Tak, zostało. Zasłyszamy? Z tego miejsca pragnę podziękować sponsorom i patronom International Medical Congress of Silesia. Na pierwszym miejscu jego magnificencji rektorowi Śląskiego Uniwersytetu Medycznego w Katowicach, panu profesorowi, doktorowi habilitowanemu nauk medycznych Tomaszowi Szczepańskiego za objęcie patronatem honorowym naszą konferencję. Przejdźmy, proszę. A także sponsorom Duda Clinic College of Dental Medicine, PSI Polskie Towarzystwo Implantologiczne, czasopismo Face and Body, Implantologia Stomatologiczna, Dental Tribune International, House of EBM, Lepolek, Angitia, Profimed, wydawnictwo PZWL, Marodent, Fagor i więcej niż lek. Tutaj proszę wszystkich uczestników o uwagę, jako że po wykładzie spośród uczestników tej ceremonii zostaną rozlosowane kody zniżkowe, aż 3 kody zniżkowe 20% na kurs więcej niż lek, LDEC i losowanie odbędzie się na końcu dzisiejszego wydarzenia. Bardzo proszę o zabranie głosu pani prorektor do spraw nauki, panią profesor Katarzynę Niedziestec.
On behalf of the Rector of Medical University of Silesia, Professor Tomasz Szczepański, I would like to congratulate for organizing this excellent Congress. I would like to congratulate to all of authors and participants. You made your best effort to present papers of the highest quality. I'm really happy with the level of both presented papers as well as scientific discussion. Since I truly believe that scientific development is an integral part of medical studies, I'm delighted to see and contact, hopefully, the future scientists. I'm aware that making small steps in science is not easy, but I know it can be a source of great satisfaction. I'm sure that you all are winners. Always I explain my students, awards and distinctions are important, but they are not the only aim of this meeting. This event is especially important to me due to my previous role. I have been the curator of the STN for the last 10 years. Since this is the first conference in which Professor Michał Cholecki, my student, decades before, has the role of the curator of the STN and also the first SIMC held online. I see it as a double success. Last but definitely not the least, I want to congratulate the organizers of the SIM conference, both extraordinary students guided by Marianna Łoskot and Piotr Lewandowski, and excellent IT, our university team. My dearest, this was a great event and I could not be more proud of you. Dziękuję Wam bardzo serdecznie, mocno Was ściskam, całuję. Thank you for your attention.
Dziękuję bardzo Pani Profesor za tak miłe słowa i teraz może Pan Profesor Cholecki chciałby też dorzucić parę słów od siebie.
Moi drodzy, jestem pełen podziwu dla Waszego zaangażowania, dla ogromnej pracy, którą wykonaliście. Jestem pełen podziwu dla jakości prezentowanych prac. Jest to olbrzymia satysfakcja. Niestety nie możemy spotkać się osobiście, tylko online, ale oczywiście lepsze to niż nic. I oczywiście w pełni zgadzam się z Panią Profesor, z Panią Prorektor, z którą tak naprawdę rozpoczynam swoją karierę naukową. W związku z czym jest mi tym bardziej miło, że w takim miłym gronie wspólnie z wami możemy się spotkać. W związku z czym czekamy na naszych następców. Wszystkiego dobrego, jeszcze raz gratuluję.
Dziękujemy serdecznie. Dalej. Jak Państwo widzą, przygotowanie tak dużego wydarzenia wymagało zaangażowania naprawdę sporej ilości osób. Dalej. Tutaj pozwoliłam sobie zaprezentować jakby skład główny organizatorów. 3 organizacje tworzące tak wielkie wydarzenie przez wiele miesięcy pracowało po to, by Państwo mogli się tu spotkać na te 3 majowe dni. Też nie obeszłoby się bez naszych wolontariuszy, którzy towarzyszyli nas w tych bardzo, bardzo intensywnych dniach konferencji. Statystyki zresztą mówią same za siebie. Pierwszy raz ta konferencja przybrała formę online z racji panującej sytuacji na świecie COVID-19. Odnotowaliśmy ponad 2250 zalogowań na platformie Zoom, gdzie odbywały się wykłady. Niektóre wydarzenia, jak wykład naszego sponsora, czy większe sesje studenckie albo doktoranckie, były transmitowane przez platformę YouTube, gdzie osiągnęliśmy ponad 2000 wyświetleń. Myślę, że po dzisiejszym dniu albo pod koniec już tygodnia, w niedzielę będzie ich co najmniej 2 razy tyle. Prowadzonych było 24 sesji, w tym 2 sesje doktoranckie i 2 sesje o tematyce COVID-19. Było przysłanych około 300 prac z 13 ośrodków polskich, ale też 13 ośrodków zagranicznych. Między innymi mieliśmy uczestników z Indii, Bangladeszu, Litwy, Łotwy, Mołdawii, Rumunii, Niemiec i pewnie zapomniałam o jakimś kraju, natomiast była to zdecydowanie konferencja międzynarodowa. Przygotowania może wyglądają bardzo sielankowo i niewinnie. Tutaj akurat nasza ekipa składa książkę abstraktów i przegląda zgłoszenia uczestników. Natomiast jest to wiele miesięcy naprawdę ciężkiej pracy, wiele litrów wypitej kawy i tysiące maili rozesłanych do różnych osób. I tak oto 12 maja mogliśmy rozpocząć naszą konferencję. Przygotowaliśmy dla Państwa taką krótką fotorelację. W tym roku nadawaliśmy do Państwa z Biblioteki Głównej Śląskiego Uniwersytetu Medycznego w Katowicach, znajdującej się na ulicy Warszawskiej. Jest to przepiękny budynek stwarzający nam mnóstwo możliwości reprezentacyjnych, co żeńska część komitetu organizacyjnego, jak widać, wykorzystała doszczętnie. Mieliśmy również gości naszych jakby takich chodzących patronów konferencji i osoby, które zawsze nas wspierają. I tak to właśnie mijały te dni. Tutaj muszę poświęcić slajd jak to już Pani Rektor dziękowała, ja również podziękuję naszym wspaniałym informatykom, panu Michałowi Nowakowi i Marcinowi Chabiorowi, którzy świetną robotę wykonali. Bez nich, bez sprzętu uczelni ta konferencja by się po prostu nie miała prawa odbyć. Także bardzo, bardzo, bardzo Panowie dziękuję. Też z tego miejsca chcę podziękować całemu działu promocji Śląskiego Uniwersytetu Medycznego. Tutaj na czele z panią Olą Wilk, która wspierała nas, jeśli chodzi o sponsorów, o gadżety, o to, żeby konferencja mogła wyglądać namacalnie. A teraz gwóźdź programu, czyli wykład honorowy naszego kuratora Studenckiego Towarzystwa Naukowego, pana profesora Michała Choleckiego. Panie profesorze, oddaję mikrofon.
Dzięki. Szanowna Pani Rektor, Państwo Dziekani, moi drodzy, przede wszystkim jest to dla mnie olbrzymi zaszczyt i wyróżnienie, że mogę się z Państwem spotkać na tym finalnym wykładzie. I muszę powiedzieć, że przez lata nigdy nie miałem specjalnie tremu przed wykładami, natomiast przed tym dzisiejszym mam olbrzymią, dlatego że studenci Państwo jesteście zawsze najbardziej wymagającymi recenzentami. Moi drodzy, ja troszeczkę zmodyfikowałem to na moje wystąpienie. Chciałem powiedzieć Państwu o otyłości na przestrzeni dziejów. Moi drodzy, przede wszystkim trzeba zdać sobie sprawę, że w czasach prehistorycznych tak naprawdę nie było problemu z otyłością. Co najmniej z 3 powodów. Po pierwsze, unikaliśmy jedzenia tłustego mięsa, zjadaliśmy znacznie więcej warzyw. Jak Państwo widzicie, mieliśmy znacznie większą aktywność fizyczną. Natomiast wraz z ewolucją, z której weszliśmy z pozycji szympansa, z pozycji małpy, jak Państwo widzicie, po prawej stronie do tej pozycji wróciliśmy, siedząc przed komputerem czy pochylając się nad komórką. Jak widzicie, historia kołem się toczy. Natomiast pierwsze wzmianki otyłości pochodzą sprzed 25 000 lat przed Chrystusem. Skąd o tym wiemy? Ta malusieńka figurka z austriackiego Willendorf przedstawia matkę naturę. Jak Państwo widzicie, jest to figurka osoby, kobiety otyłej, z dużym biustem, dlatego że, drodzy Państwo, otyłość kojarzyła się z dobrobytem, z dobrym zdrowiem i tak również przedstawiała to matka natura. Kolejnym symbolem obfitości, możliwością przetrwania była matka natura pochodząca z tureckiej Anatolii. To mniej więcej 5500 lat przed Chrystusem, również otyła kobieta, również symbol obfitości, przetrwania, dobrego zdrowia i najpełniej bogactwa. Przez wiele lat otyłość kojarzyła się wręcz pozytywnie. Dopiero w ostatnich latach, kiedy mass media zasypują nas zdrową żywnością, aktywnością fizyczną, ta otyłość ma raczej charakter pejoratywny. Gdybyśmy się teraz przeszli do antycznego Egiptu, czyli 2000 lat przed Chrystusem i spojrzeli na rzeźby na grobowcu Mereruka, to był faraon z VI dynastii, tam możecie Państwo zauważyć dosyć szczupłego służącego, który karmi swojego pana, czyli faraona, który ma znacznie obfitsze kształty niż ten nieszczęsny niewolnik. Drodzy Państwo, pewna ciekawostka. Królowa Enehepi około 2000 lat przed Chrystusem, która na podstawie danych historycznych wcale nie była osobą szczupłą, tylko była kobietą otyłą. Natomiast to oczywiście nie przeszkadzało informatykom i różnym rysownikom przedstawiać to jej jako osoby szczupłej i pięknej, młodej kobiety. Drodzy Państwo, ojciec medycyny Hipokrates już w czasach starożytnych zauważył, że nagła śmierć częściej dotyka osoby z otyłością niż osoby szczupłe. Co więcej, uważał, że przyczyną zaburzeń miesiączkowania czy zaburzeń płodności również jest otyłość. I to są pierwsze wzmianki o tym, że ta otyłość wcale nie była taka zdrowa, jak mogło się było wydawać. I oprócz tego, że była co prawda symbolem dobrego zdrowia czy symbolem pozycji społecznej, to wcale nie była takim czynnikiem, który poprawiał jakość i długość życia. 500 lat później słynny perski lekarz Avicenna zauważył, że chorzy z otyłością mieli słodki smak moczy. To są pierwsze informacje o cukrzycy. Wtedy wszystko rozpoznawano mnemoleptycznie. I on również potwierdził, że otyłość jest szkodliwym czynnikiem dla naszego zdrowia. 400 lat przed Chrystusem przenosimy się do Indii. Szarak i Szuszrut to byli wówczas jedni z najlepszych lekarzy, jeden zajmował się ziołolecznictwem, drugi chirurgią. Jak Państwo widzicie, również chirurgią zaćmy. Chirurgia zaćmy ma bardzo bogatą historię i oni również zauważyli słodki smak moczu osób otyłych spożywających potrawy słodkie i tłuste. Tu mamy bezpośrednie przełożenie i mówimy również o otyłości. W Tybecie w XVII wieku tamtejszy regent zauważył, że nadmierna masa ciała powoduje choroby i skraca czas życia. I co ciekawe, wymyślił 2 sposoby walki z otyłością, które bardzo szeroko propagował. Pierwszym z nich był intensywny masaż z użyciem mąki z grochu, a drugim spożywanie przełyku, sierści i wilczego mięsa. Tak jak Państwo widzicie, sposoby leczenia były bardzo, bardzo ciekawe. Ale drodzy Państwo, tak naprawdę dopiero w XVI wieku powstało najsłynniejsze dzieło o anatomii człowieka przez Andrasa Vesaliusa wydane, gdzie po raz pierwszy zwrócił uwagę na otyłość z punktu widzenia medycyny. XVII wiek Teofil Bonetus po raz pierwszy wykonał sekcję zwłok osoby otyłej i dokładnie opisał rozmieszczenie tkanki tłuszczowej, również w aspekcie otłuszczenia serca, otłuszczenia wątroby, a w XVIII wieku Jean-Baptiste Morgani opublikował dzieło, które się nazywało o siedzibach i przyczynach chorób. I tu po raz kolejny dał jasno do zrozumienia, że otyłość jest czynnikiem szkodzącym zdrowiu i skracającym życie. Ale dopiero w XIX wieku William Watt, który był brytyjskim XIX-wiecznym chirurgiem i taką sławą, jeżeli chodzi o medycynę, wydał dzieło pod tytułem Comments of Corpulency, gdzie również opisał otyłość, jak Państwo widzicie w tym załączonym obrazku z pierwszej strony, który również przypisywał wiele niekorzystnych działań z punktu widzenia ludzkiego zdrowia i życia. Ale po raz pierwszy otyłość matematycznie opisał Belk. Adolf Quetelet w XIX wieku, który wymyślił wskaźnik masy ciała, którym zresztą posługujemy się do dzisiaj. Co prawda mówi się, że jest bye-bye BMI, ale to BMI dalej jest w pewnym stopniu aktualne i póki co lepszych wskaźników już nie ma, jest tak rozpowszechnione, że wszyscy z tego BMI korzystamy. I gdybyśmy przeszli przez XVII, XVIII, XIX wiek, to zobaczcie Państwo, że pierwsza sekcja przeprowadzona na osobach otyłych, klasyfikacja chorób, które obejmują m.in. otyłość, pierwsze pomiary wydatku energetycznego, prawo zachowania energii, zespołu obturacyjnego bezdechu sennego został uznany jako powikłanie otyłości w roku 1866 i wreszcie dochodzi do budowy kalorymetru, czyli wszystko idzie w tym kierunku, aby rozpoznawać otyłość, wiązać ją z poszczególnymi chorobami, a w końcu rozpocząć leczenie. Ale drodzy Państwo, przenieśmy się do malarstwa. Jak Państwo wiecie, XVII wiek, Paul Rubens, Wenus z lustrem między innymi. Zresztą to teraz się mówi o rubensowskich kształtach i wtedy o kobiety z otyłością z punktu widzenia Rubensa były pięknościami. Przejdźmy na drugą stronę. Alessandro del Borro to był taki hiszpański pułkownik, który są nie tylko z olbrzymich liczby zwycięstw, z niezwykłego bogactwa i odwagi, ale również słynął z niezwykłego apetytu i nadmiernej masy ciała, jak na tym pięknym obrazie Charlesa Mellina. I dopiero, drodzy Państwo, w XX wieku otyłość została postrzegana jako coś pejoratywnego, jak na tym płótnie Francesca Botero właśnie z 1996 roku. Ale moi drodzy, jaka jest w takim razie symbolika otyłości? No przede wszystkim samiec alfa, męska siła, dominacja, ale również kobiece krągłości. Znowu wracamy do Rubensa jako piękno. I wreszcie dziecko zdrowe, prawidłowy rozwój. Dziecko duże, dziecko wyglądające jak ludzi Michelin było symbolem zdrowia. Drodzy Państwo, zwróćcie uwagę, że każda babcia goni małe dziecko z łyżeczką zupki, z jakąś kanapką, o dziecko zjedz, będziesz duże i zdrowe. Jeżeli się mówi o jakimś malutkim, herlawym dziecku, to było postrzegane przez nasze babcie jako raczej niezdrowe albo chory. Dziecko zdrowe musiało być duże. Moi drodzy, tak się śmiesznie składa, że my również inaczej się postrzegamy. Każda kobieta stająca przed lustrem, niezależnie od tego, czy jest wicemistrz świata, mistrz Polski, zawsze jakiś mankament znajdzie. Ale z drugiej strony, jeżeli spojrzymy na mężczyznę, który wygląda różnie, a wydaje mu się, że zawsze wygląda jak superhero. Moi drodzy, zwróćcie uwagę na samookreślenia się chorych na otyłość. Misiek, beza, kluseczka, baryłka, ponczuś, puszysta. Zwróćcie uwagę, że po pierwsze, te samookreślenia są bardzo blisko związane z posiłkami, a z drugiej strony mają taki wydźwięk wcale nie pejoratywny. Raczej mile się kojarzy beza, mile się kojarzy kluseczka, mile się kojarzy puszysta. Czyli znowu nie mamy tu odniesienia do czegoś negatywnego, wręcz odwrotnie. Jak pacjenci siebie określają? Konkretna baba, dobrze wyglądam, widać, że mi nie brakuje, zdrowo wyglądam, jestem dobrze zbudowany czy dobrze zbudowana. Zobaczcie Państwo, więc znowu ta otyłość nie jest postrzegana w sposób negatywny, tylko wręcz w aspekcie dobrobytu, dobrego zdrowia czy symboliki samca alfa. No więc w takim razie, że mówimy o symbolice, to jaka jest symbolika jedzenia? Przyjemność, pocieszanie, dom rodzinny, poczucie bezpieczeństwa, świętowanie, dobrobyt, dostatek, radość, znowu same pozytywne skojarzenia, żadnych negatywnych. Ale jaki jest przekaz kulturowy? Chleba się nie wyrzuca, przez żołądek do serca, czyli jak kobieta kocha, znaczy, że dobrze gotuje. Jeżeli mąż tyje, znaczy, że kobieta go kocha, bo te posiłki są smaczne, bo te posiłków jest dużo. Biedziaki częstują, kochani przez gotowanie, znowu same pozytywne skojarzenia. Kto chleba nie chce, nie warty kołacza, lepiej zjeść i odchorować, niż by się miało zmarnować. Od przybytku głowa nie boli, lepiej dać piekarzowi niż lekarzowi. No jak Państwo widzicie, no, anegdotek różnych jest bardzo mnóstwo. Zwróćcie uwagę, jak zmieniały się postrzegania i cele, do których dążyliśmy. 20 lat przed Chrystusem modliliśmy się przed posążkami takimi jak Wenus Willendorf, czyli otyłe kobiety. W XX wieku no, jesteśmy coraz bardziej otyli i modlimy się do bóstw, które są raczej szczupłe. I tak, moi drodzy, naprawdę podsumowując, sama wiedza nie jest niestety dostatecznym orężem przeciwko nieprawidłowym nawykom, dlatego że czym skorupka za młodu nasiąga, tym jajeczko na starość trąci. Ale moi drodzy, dużo zależy od nas. Nic nie jest niemożliwe. My sami kreujemy rzeczywistość, sami kreujemy to, co z nami się dzieje, sami potrafimy wyrzeźbić naszą sylwetkę, czego Państwu, a przede wszystkim sobie życzę. Bardzo dziękuję za uwagę.
Bardzo serdecznie dziękujemy za interesujący wykład. Teraz, proszę Państwa, przejdziemy do ogłoszenia wyników naszej konferencji. Na to wszyscy na pewno czekacie z niecierpliwością. Natomiast przedtem jednak chciałam jeszcze podziękować kilku osobom. Przede wszystkim podziękuję panu Przemysławowi, którego pominęłam, a który również był tym trzecim informatykiem ze zdjęcia. Panie Przemku, bardzo przepraszam, ale bardzo dziękujemy za pana pomoc. Dziękuję oczywiście pani profesor Katarzynie Michisted za nieocenione wsparcie i pomoc przed konferencją, w trakcie konferencji. Pani profesor, bez pani nie dalibyśmy rady. Dziękuję bardzo panu profesorowi Michałowi Choleckiemu również za wsparcie, za wyrozumiałość, za potrzebną pomoc zawsze, gdy jej potrzebowaliśmy. Dziękuję Komisji Naukowej, dziękuję profesorom, adiunktom naszej uczelni za to, że Państwo znaleźli czas, poświęcili często swój wolny czas dla studentów, za cierpliwość, za profesjonalizm i za zaangażowanie w dyskusję, a przede wszystkim dziękuję Wam, uczestnikom, za mnóstwo pracy, jaką włożyliście w przygotowanie Waszych prezentacji. Wasze badania często trwały wręcz lata, także tym bardziej wielkie brawa dla Was. Ja wiem, że nie każdy z Was będzie mógł zająć w tym roku konkretne miejsce na podium, ale mam nadzieję, że to Was nie zniechęci do dalszej pracy naukowej, nad rozwojem Waszego dorobku naukowego i dalszych badań w dziedzinach, które Was interesują. Ja Wam od siebie życzę wszystkiego co najlepsze i wielu, wielu sukcesów. A przede wszystkim chciałabym podziękować tutaj obecnemu Piotrowi Lewandowskiemu, którego śmiało mogę nazwać głównym mózgiem naszej konferencji, bo bez Piotra na przykład nie mielibyśmy do czego do Państwa mówić i Państwo by nie mieli nas jak oglądać, dlatego że Piotr również zadbał o to, żeby ta konferencja w formie online była dla wszystkich i osiągalna, i dostępna. Także Piotrze, bardzo, bardzo dziękuję.
Tobie również, Marianna, jak głównemu organizatorowi. Bez Ciebie również ta konferencja nie mogłaby się odbyć.
Okay, so finally we would like to announce the result of International Medical Congress of Silesia. Let's begin with doctoral session, and the results of doctoral session will be presented by representatives of doctoral students government Bartosz Skowronek i Agnieszka Wiórek.
So in the first place, I would like to thank all the participants for outstanding and amazing works presented during the conference. I would also would like to thank our colleagues of Student Scientific Associations. And let's proceed to the results. I bet everybody is waiting for them.
So, without further delay, the first award in the Doctoral Clinical Medicine session goes to Karolina Kozioł, Anna Brzuska, Beata Kazek, Agnieszka Campino-Skorczyca, Agnieszka Babraj, Ewa Emich-Widera.
And the second place goes to
Sorry, first let's
I still see the first place.
This is the first place in monitor.
Oh, thank you.
Okay, thank you very much. The second award goes to Zygmunt Gofron, Monika Kabała, and Katarzyna Gibas. And the third place goes to Jakub Nastaj, Daria Nowak, Jacek Skalski, Sylwia Swoboda, and Edyta Zdroj.
And for the session of scientific medicine, the first place goes to Karolina Beton and Beata Brożek-Puluska. The second place goes to Mateusz Grabowski, Daniela Liśkiewicz, Arkadiusz Liśkiewicz, Konstancja Grabowska, and Jarosław Balski. Oh, here comes the accent. And the third place goes to Konstancja Grabowska, Natalia Ponder, Marta Nowacka-Chmielewska, Daniela Liśkiewicz, and Jarosław Balski. So, thank you again. We'll now pass the mic to our colleagues.
Okay, now we will go to the students' sessions. It is a very nice pleasure to present the results of our and yours hard work. We will begin from the session of anesthesiology, intensive care, and emergency medicine. The first prize in this session goes to Zbigniew Butowski and Karol Gruca for the work therapeutic plasma exchange as a rescue therapy for severe COVID-19 case series. The second prize goes to Kamil Witosz and Olga Wojnarowicz, and the third prize goes to Zbigniew Butowski. The next session is the session of basic sciences. Please.
Next slide,
please. Okay. The first prize goes to Tomasz Techmański, Monika Szultysik, Bartosz Stanek, Wiktoria Sobor, Maja Esterok for the work biochemical aspect of obesity paradox in patients with non-ischemic dilated cardiomyopathy, the role of leptin, adiponectin, and TNFR1, TNFR2 receptors. The second prize for the session of basic sciences goes to Agnieszka Brzezińska, Marlena Zając, and Monika Borowiecka, and the first prize goes to Anna Gill. Now we will announce our awards for the session COVID-19. It is the session that we organized for the first time.
And first place goes to Jakub Szczerba, Alicja Poroczek, Maciej Poniedziałek, Łukasz Białek, Dariusz Krawczyk, whose authors are of continuous temperature monitoring system for persons in quarantine and hospitalized patients. The second place goes to Julia Osińska i Monika Homa with case fungal co-infection in severe COVID-19. And the first place goes to Zbigniew Putowski, Katarzyna Meger, therapeutic plasma exchange as successful therapy for severe COVID-19, a case report.
Okay, now the second COVID-19 session, because the COVID-19 works, there were many this year, and we had to organize 2 sessions for COVID-19. And the first prize goes to Alicja Wojtyniak and Ada Sterczewska for work ocular complaints from students during COVID-19 pandemic. The second prize goes to Monika Saczyńska and Natalia Sajdak. Sorry, the first place was executive. So the first place goes to Monika Saczyńska and Natalia Sajdak for work ocular manifestations in patients with COVID-19. The second prize goes to Aleksandra Krawczyk, Aleksandra Surmacz, and Aleksandra Stopa. The second place goes to Alicja Jowczyk and Przemysław Kasiak. And the first prize goes to Nikola Dyrek, Agnieszka Wikarek, and Małgorzata Niemiec.
Congratulations.
The next session is the session of dermatology. And the first prize goes to Stanisław Anczyk, Maciej Stępień, Michał Raczyński, and Maja Woźniakowska for the work Influence of the Usage of Respiratory Protection Measures on the Condition of Acne-Prone Skin.
The second place goes to Oliwia Warmusz, Magdalena Zając, Gracja Ryznar, Piotr Lewandowski for work tissue hemostasis in soft toward thrombogenesis in psoriatic plex.
And the first prize goes to Szymon Mućka, Magdalena Mróz, and Martyna Miodońska for the third prize goes to Szymon Mućka, Magdalena Mróz, and Martyna Miodońska for the work effect of the SARS-CoV-2 infections on the progression of atopic dermatitis. Okay, let's go to the session of dietetics and nutrition. The first prize goes to Michał Tworek, Agnieszka Wikarek, Paulina Kosińska, Ewa Łapczyńska, and Jakub Maciurzyński for the work Superfoods and Dietary Supplements during COVID-19 pandemic. What we believe in and how accurate it is. Congratulations. The second prize goes to Magdalena Nowak and Zuzanna Olejarz. And the third prize goes to Marika Blazło, Barbara Janota, Martyna Czapla, Kamil Mąkosza, and Natalia Ziemba.
And now we'll begin with, let's go to the session of gynecology and obstetrics. And the first place goes to Karolina Gasz and Karolina Czarnecka for work Why the Polish Women Chose Hormonal Contraception, a cross-sectional study. Second place goes to Elina Mixta
for the work Impact of Vaginal Dryness on Postmenopausal Women. It is the first international prize today. There are 2 more. Elina Mixta is from Riga Strelina University from Latvia. We are very proud that we have also winners outside the Poland.
Congratulations, Elina. And the third place goes to Marcin Mycyk, Karolina Nowak, Anna Naleśniak, Zuzanna Olejarz, Karolina Nawrotek for work the menstrual cycle at the time of the plague.
The next session is the session of internal medicine. The first place goes to Adam Borek and Franciszek Grzymała for the work Characterizations of Clostridoides difficile, Hospital Outbreak in 33 Beds, Internal Ward of District Hospital, Southern Silesia. The second prize goes to Małgorzata Grabarczyk, Marta Gorczyca, Paulina Kosińska, and Katarzyna Klimek. And the third prize goes to Natalia Łukal, Katarzyna Stupińska-Borówka, Aleksandra Gładyś, Maciej Gucwar, Agnieszka Stępińska, and Wiktoria Strona.
Okay. The session of internal medicine second. The first place goes to Stanisław Surma for the work Hyponatremia induced by thiazide and thiazide-like diuretics. Thank you, Good. The second place goes to Sylwia Kozak and Aleksandra Gładyś. And the first place goes to Karolina Janiec-Rojek, Karolina Baranowska i Karolina Jakubowska.
Okay, let's begin with the cardiological session. The first session is session of invasive cardiology and cardiothoracic surgery. The first prize goes to Sofia Antoniuk, Tomasz Gołębski, Grzegorz Wypych, Marek Zielonka, Olivia Okon, and Alexandra Nowak for the presentation Repeated Dose of Contrast Media and the Risk of Contrast-Induced Acute Kidney Injury in a Broad Populations of Patients Hospitalized in Cardiology Department. The second prize goes to Natalia Tomecka and Maciej Pękała. And the third prize goes to Andrzej Szydłowski, Anna Szydłowska, and Alicja Gałeczka.
Now the session of neonatology and pediatrics. The first place goes to Alicja Wojtyniak, Karolina Trząska, Natalia Ogarek, Barbara Pindur for work nutritional status and eating habits of children with cystic fibrosis, one-center study. The second place goes to Aleksandra Moskowiak, Julia Strudzik, Anna Wilk. And the second place goes to Aleksandra Stefanik i Michał Widu. And the first place goes to Kinga Szopinska and Karolina Tracz.
Okay, let's go to the session of neurology and neurosurgery. The first place takes Sofia Antoniuk, Natalia Rafalska, Olivia Okon, and Alexandra Nowak for the work The Influence of Seasonality, Vitamin D Supplementation, and Other Extrinsic Factors on Relapse Occurrence in Patients with Relapsing Type of Multiple Sclerosis. The second prize goes to Łukasz Antkowiak, Piotr Stogowski, Hubert Mado, Michalina Rucińska, and Zuzanna Nowaczyk. And the third prize goes to Karolina Jakubowska, Karolina Janiec-Rojek, and Karolina Baranowska.
Let's go to session of non-invasive cardiology 1. The first place goes to Sugar Mabuzan-Suren, Aneta Izimolong, Magdalena Balwierz, Andrzej Halfar, Miłosz Cempa for evaluation of pharmaceutic impact on contractility recovery in patients with newly diagnosed acute-dilated cardiomyopathy. The second place go to Konrad Klocek, Katarzyna Klimek, Michał Tworek, Maciej Zwolski, Dominik Będkowski. And the first place goes to Aleksandra Gamra.
Okay, the next session is the session of non-invasive cardiology 2. The first place goes to Tomasz Klocek, Magdalena Drewnowska, Karolina Jakubowska, and Mateusz Gochowski for the work Prevalence of Obstructive Sleep Apnea in Patients with Pulmonary Arterial Hypertension. The second prize goes to Karolina Jakubowska, Dominika Dziadosz, Dominika Kieł, Tomasz Klocek, Magdalena Drewnowska, and Michał Wspólnik. And the third prize goes to Maria Stec, Daniel Gonko, Marta Gorczyca, Adam Grzebinoga, Jakub Roman, and Agata Suleja.
Now we move to the session of physiotherapy and orthopedics, and the first place goes to Tomasz Król, Jakub Drąg, Adam Smolik i Tomasz Włoch for the work comparison of post-surgical complication after total hip and knee arthroplasty in the relation to the preoperative assessment of health. The second place goes to Maciej Kuś, Mikołaj Chorodecki, Kamil Bańkowski. And the third place goes to Kinga Kluska, Elżbieta Ferenc, and Joanna Dudek.
And the third place goes to Kinga Kluska, Elżbieta Ferenc, and Joanna Dudek.
Congratulations.
Now let's move to the session of psychiatry and sexology. The first place for the work Quality of Life, including the sexual life of those staying in prisons, goes to Daria Kozina. Congratulations. The second place goes to Patryk Główczyński, and the third to Anna Gogola and Agnieszka Goryczka.
Now we move to the session of public health and healthcare. The first place goes to Barbara Lew for the more close look at medical students. Basic ophthalmic knowledge and its use verified by the last year academic online lecturing. The first place goes to Natalia Tekiela, Marcin Cholewa, Karolina Piskorowska, Paulina Rutecka for the work awareness of high school students about HPV and cervical cancer. The second place goes to Karol Krystek, Kamila Kuśpiel, Katarzyna Maciejewska. And third place goes to Patrycja Rozwadowska, Kamila Dubajk, Wojciech Dubajk, Adrianna Senkowska, and Anna Trybus.
Okay, let's move to the session of public health and healthcare too. The first place for the work Children of the Screen Generations is for Magdalena Nowak, Karolina Nowak, and Maria Nieć. The second prize goes to Marta Oleksa, Aleksandra Spień, and Dawid Wiśniewski. The second place goes to Mateusz Szymała, Dominika Naszauer, Patrycja Krakowska, Daniel Tałajczy, and Paula Próżna. And the first prize goes to Ashish Paul from the Dhaka Medical College in Bangladesh.
Congratulations. Okay, now we move to session of radiology, radiodiagnostic and nuclear medicine, and the first place goes to Madara Ratnice. Sorry if I read it wrong. For the case MRI T2N quantitative DUI ADC imaging in local colorectal cancer staging and evaluation of therapy response.
Madara is the second laureate from Riga Stradina University.
The second place goes to Emilia Hruściel, Anna Lis, Iga Paszkiewicz, Jakub Kufel, Piotr Mazurek, and Szymon Adamski. And the first place goes to Kacper Lipiński and Aleksandra Królikowska.
Okay, the next session is the session of stomatology. The first prize goes to Ewelina Dąbrowska and Damian Gruza for the work The Comparison of Occlusal Patterns and Malocclusion Disharmonies Between Children with Down Syndrome and Healthy Children. The second place goes to Aleksandra Dyćcik, Gabriela Zdrojewska, Bartosz Dalewski, Łukasz Pałka, and Ewa Sobolewska. And the second place goes to Alicja Kula and Jolita Kalinowska. The winner of the third place is Olivia Barmusz and Karol Panasewicz.
And now we move to the session of surgical specialties 1, and the first place goes to Andrzej Rak, Przemysław Rodzik, Adam Salva for the work high neutrophil to lymphocyte ratio as a prognostic factor of post-operative complications following distal pancreatectomy. The second place goes to Izabela Karpińska, Gabriela Kanclerz, Nina Skalska-Dziobek, Jakub Strojek. And the third place goes to Karolina Majewska.
And the last but not the least session the session of surgical specialties number 2. The main prize goes to Emilia Mandalka, Agnieszka Adamiec, and Hanna Dańkow for the work Keratoconus, Symptoms, Age of Detection and Treatment Questionnaire Study. Second prize goes to Klaudyna Bugla, Katarzyna Klimek, Piotr Kut, and Michał Tworek. And the first prize goes to Marta Gromada, Julia Graca, Paweł Gruchalski. Congratulations for all winners and all their participants. The level was really high and the committee had very hard work to choose the best works. Your prizes will be sent up to 3 weeks after our conference by post. And the certificates for laureates and participants will be sent today and tomorrow to email for the first author, the email that you provided in the registration form.
Thank you all for your attention, and we hope to see you next year, so have a nice day. Także dziękujemy Państwu.
Mam nadzieję, że w przyszłym roku zobaczymy się z Państwem już stacjonarnie albo przynajmniej hybrydowo w Katowicach w Ligocie w maju.
Tak, zdecydowanie na to liczymy. Dziękujemy za obecność Państwu dziekanom, Pani Rektor oczywiście, Panu Profesorowi Michałowi Paleckiemu również. I zaraz się skontaktujemy z Panem Michałem, naszym informatykiem, a propos losowania 3 zniżek 20% na kurs Więcej niż lek.
Natomiast do każdego maila zostaną dołączone również kupony zniżkowe na kursy House of EBM, kursy z zakresu Evidence-Based Medicine. Dodatkowo zwycięzcy otrzymają pierwszego miejsca darmowe dostępy do pierwszej części takiego kursu.
Dla zwycięzców sesji stomatologicznej przewidziana jest także nagroda fundowana przez naszych sponsorów Duda and Invest Clinic. Jest to wyjście na kongres implantologiczny, a także tygodniowe praktyki Duda Dental College and Center o wartości ponad 2000 zł. Dodatkowo panowie doktorzy Mariusz Duda i pan doktor Christopher Inves wśród zwycięzców sesji wybiorą zwycięzcę według nich, który otrzyma możliwość voucher na zabieg wybielania zębów metodą Prevdent w klinice Duda Clinic. O tym wszystkim będzie informować Państwa poprzez maila, a także będzie to opublikowane na naszym Facebooku, więc zachęcamy go obserwować dalej.
na kanapie, w bibliotece ze znajomymi.
W gabinecie przy herbatce, z muzyką w tle.
Przy biurku, we własnym domu, ewentualnie z kotem na kolanach.
Najbardziej to lubię wieczorem.
Ale w efekcie często siedzę cały dzień.
Lubię na papierze.
Tylko online.
Lubię regularnie.
Lubię efektywnie. Lubię elastycznie.
No i wtedy praca to przyjemność.
I właśnie dlatego lubię więcej niż lek. Lubię więcej niż lek.
Lubię więcej niż lek.
Czy nas też będzie widać na zdjęciu z Michałem, czy nie, słuchajcie?
Zaraz się okaże.
Bo to zdjęcie zawsze było takie pamiątkowe i ja te zdjęcia gdzieś mam w swoim archiwum.
Tak, zapraszamy tutaj pan Michał, informatyk nas jak zwykle zaskoczył. Zapraszamy do wspólnego zdjęcia, przynajmniej takiego, ale proszę o łączenie kamery. Ja tu jestem już z moimi dziećmi, tak jesteśmy gotowi.
Pani Maria,
czy mogę prosić?
Zmieścimy się wszystko.
Zmieścimy się. O, jest pani docent.
Oj, pani profesor, dziekan. Dobrze, ale my chcemy ten ekran, zrzut z ekranu pani Michale też mieć jako zdjęcie. Nie wiem, czy to jest możliwe. Wysłane potem do nas.
Tak, będzie to możliwe.
O, pan Bogdanek jest też.
Tylko proszę wszystkich uczestników o włączenie kamer, jeżeli to możliwe.
No i pięknie.
Mam nadzieję, że jeszcze ktoś dołączy. Tak naprawdę wszyscy, już pani dziekan też mówiła, wszyscy jesteście tutaj wygranymi, więc o te miejsca, które gdzieś tam przemknęły, na pewno nie chodzi.
Ale w następnym roku będzie dużo lepiej.
No, jak najbardziej, ale zawsze jest limitowana liczba miejsc na podium, ale ja to podkreślam, że to jest jakiś wybór komisji. Natomiast tego, czego się nauczyli i napisali, tego im nikt nie zabierze. Także
udział, zabawa i doświadczenie.
No trochę konkurencji jest, to tak już nigdy
tak, oczywiście.
Tak nie może być, ale dzięki temu jest poziom i jest adrenalina. Ale
Prawda, sesja doktorancka była na bardzo wysokim poziomie. W tym momencie
to zdjęcie ma być, bo tutaj staram się wyprostować, ale nie wiem, czy mi się udaje.
Cały czas jest to nagrywane na YouTubie, więc wszystkie osoby, które miały włączone kamery, będą też widoczne.
Ile Piotr nas obserwuje na YouTubie?
Około 150 osób.
Słuchajcie, naprawdę ja jestem pod wrażeniem naszych informatyków. To, że to ogarnęli i wyłączyli, ja byłam przerażona, bo każdy z tych uczestników wysyłał prezentację z własnego komputera. Jeszcze w tamtym tygodniu z panem Piotrem rozmawiałam, że to może się nie udać i aż się boję, co będzie. Także ja tutaj naprawdę jestem, no nisko się kłaniam.
System nie padł.
System nie padł, wszystko zadziałało. Po raz pierwszy online także.
Na taką skalę.
No na taką skalę i mega czasowo wszystko się udało spiąć. Tak naprawdę na żywo to zazwyczaj bywało dłużej. To nie można było takiego reżimu czasowego trzymać. Zawsze pamiętam, że nam się to trochę rozjeżdżało w czasie. Machamy, słuchajcie.
Machamy, machamy!
Prawie jak na Zachowskiego.
Muzyczka jak wspomniałem.
Czyli się żegnamy. Super. Bardzo Państwu dziękujemy.
Wszystkiego dobrego. Gratuluję raz jeszcze.
Gratulujemy.
Dziękujemy za zaproszenie i jeszcze raz gratuluję, gratuluję, gratuluję.
Proszę teraz świętować.
Do zobaczenia.
Do zobaczenia.
Dziękujemy serdecznie i gratulujemy wszystkim.